അല്ലെ ഒന്ന് രണ്ട് പടം എടുക്കണ്ടേ എല്ലാരും കൂടെ ഉള്ളപ്പോ. കമല
We will do it.
ആണോ? ഹായ്.
Hello, Jyoti.
Yeah.
Jyoti.
Hello, everybody.
ജ്യോതി
Madam, ഞങ്ങൾ ഈ വീഡിയോ
പടം എടുക്കണ്ടേ എല്ലാരും കൂടെ ഉള്ളപ്പോ.
So we can share, madam.
Okay, at the end of my talk, I just thought I'll have a video. Yeah.
Okay.
All the best, everyone.
Thank you, ma'am.
Best wishes.
Yes. With God's help.
ഹസീനയും പേര് മാറ്റണം, മനോജ് വിസിയുടെ പേര് മാറ്റി.
എല്ലാവർക്കും മാറ്റണം. രാധിക, you go to
ജ്യോതി
പേര് മാറ്റണം.
അതെങ്ങനെ മാറ്റണം സർ? പേരെങ്ങനെ മാറ്റും?
മൂന്ന് ഡോട്ട് കണ്ടോ? 3 ഡോട്ട്
on your video thing.
കണ്ടില്ലേ?
Put your thing on your thing video, and then you can see mute and then 3 dots. 3 dots പോയിട്ട് മാറ്റുക.
എല്ലാരും മനോജ് സാറിന്റെ പേരാ.
അതെ.
എന്നാലും വിഷ്ണു മനോജ് മാറ്റി കൊടുത്തു.
ജ്യോതി കണ്ടില്ലേ? Keep your cursor on the picture, Jyoti, and you get 3 dots.
പാർട്ടിസിപ്പൻസിൽ ക്ലിക്ക് ചെയ്തിട്ട് നമ്മുടെ ഇതിന്റെ മേലെ പോയാലും റീനെയിം എന്നൊരു ഓപ്ഷൻ കിട്ടും.
Okay.
Start. Time to start.
So when we should start no?
Yeah, let us. I think we have 300 plus
300 participants.
മനോജ്, ഞാൻ ഒരു കാര്യം കൂടെ ചോദിച്ചോട്ടെ. ഈ ചാറ്റിലുള്ള ക്വസ്റ്റ്യൻ നമുക്ക് മാത്രമേ കാണാൻ പറ്റുള്ളൂ, അതോ ഡെലിഗേറ്റ് ഇതിൽ അവർക്കും കാണാൻ പറ്റുമോ?
The questions can be seen. Change ചെയ്തിട്ടില്ല. So you can chat-ലുള്ളത് you can
Chat box can be seen, madam. Q&A I think should be managed by us.
So they should ask their questions in the Q&A.
Yeah. They should ask them to. Initially, you can tell them to ask all questions in Q&A box. Chat box is mainly for communication, housekeeping, greetings, and all that. Questions for session on the Q&A box. On announce ചെയ്യണം ഇടയ്ക്കിടയ്ക്ക്.
Okay. ശരി. അപ്പോൾ Q&A box-ലാണ്. അല്ല.
I think we are live already, so probably 1:04 1:05 we should start. More than 5 minutes we should not delay.
Okay.
Shall we start, sir?
Yeah. Start.
A warm good afternoon to all the respected consultants, healthcare professionals, and my colleagues. Myself, Dr. Shilpa Arshekar, would like to take the privilege in welcoming you all to the Kerala State Neocon 2021, the 27th Annual State Neonatology Conference of NNF Kerala, hosted by NNF Thiruvananthapuram and IAP Thiruvananthapuram. First, we'll start the program with a silent prayer. As you all know, In view of the current pandemic situation, we have decided to conduct the conference on an online platform from 6th to 9th May 2021. The theme for this year's Neocon is Comprehensive Preterm Care. As the COVID-19 continues to spread extensively, our healthcare systems are battling to bring it under control. And several months into this pandemic, many of our routine essential health systems worldwide have been disrupted. But amidst all this, we must not forget about the essential care that must be imparted to the newborns as they form the core of the next generation in whose hands our worlds rest. In this context, today, on the 6th of May, we are conducting an online CNE regarding the essential principles of newborn care and resuscitation for the nursing fraternity from 1 p.m. to 6 p.m. with credit hours by the Nursing Council. Being an online session, we could reach out to a large number of participants, and we are very proud and happy to inform that almost 500 candidates have registered for today's session. On this note, first, I invite Dr. PMC Nair sir, Organizing Chairperson of NNF Kerala and National Faculty of Neonatal Resuscitation Program, to deliver the welcome address. Over to you, sir.
Okay. Thank you, Dr. Shilpa. Good afternoon and warm welcome to all of you. We all know that nurses are the real backbone of any neonatal care program. More than 80% of the neonatal care in the NICU is being done by the multifaceted nursing staff. So as the organizing chairperson, I am extremely delighted to welcome such a large gathering of about 450 nurses for this academic feast. The ravaging COVID-19 pandemic has forced us to conduct this CNE totally as a virtual one, but with all the limitations, we have tried to make it enjoyable as much as possible, and we will also provide the course materials later on. This CNE is being arranged in Anantapuri Hospital and Research Foundation by none other than Dr. Kamala, who is the Chief Neonatology Consultant, as well as one of the Director Board members. So wishing all of you a nice academic feast, and thank you.
Thank you, sir, for that warm welcome. Today's program coordinator, as sir has already said, is Dr. Kamala Swarnam, Senior Consultant Neonatologist in Anantapuri Hospital and Research Institute. Over to you, madam, to do the honors.
A very warm welcome to all. We will start today's events with the inaugural session. Dr. V.C. Manoj needs no introduction among the neonatology fraternity. He is the president of NNF Kerala, National Executive Member of NNF India, and National Executive Member of South Zone Neonatology Chapter of IAP. He is also the Senior Consultant Neonatologist at Jubilee Mission Medical College and Research Institute. He has numerous academic credentials in the form of national and international journals and neonatology textbooks to his name. He is also the State Academic Coordinator in Advanced NRP Training and Research Guide for IAP and NNF Postdoctoral Neonatology Fellowship, and well known for the numerous NRP training sessions conducted enthusiastically. I welcome you, sir, to officially inaugurate the online CNE for nurses.
Thank you so much, Dr. Kamala, for those kind words. Respected seniors and my dear friends, warm greetings from National Neonatology Forum Kerala. It is a humbling moment, a proud moment for all of us here, the members of National Neonatology Forum Kerala, to host this Nurses CNE as a premier, the first program of our state Neocon. This year, as was rightly put, we are fortunate enough. It's said that we should always convert our difficulties into challenges and opportunities. So rather, we are fortunate to have more and more of you join us, because we had to go online this time, breaking from the usual tradition of having physical meetings. And we are very fortunate to have delegates for today's session from all over the country, and some from outside the country watching us through YouTube as well. So it's a proud moment for us to begin our conference with this, and it's more so because today is the eve of the International Nurses Week, and we all know nurses are the pillars of neonatology. And actually, as is rightly said, NICU nurses hold the future literally in their hands. So that is the importance. Any newborn ICU or any neonatal program cannot boast of any success without skilled and trained nurses. So the key to neonatology is nurses. That is the reason why we NNF Kerala decided to have nurses CNEs all throughout all our programs in all every year, and we have been religiously following it for last 2-3 years. And we hope to take it to the next level in the future years, probably once the pandemic clears. On 12th of May, we are having the International Nurses Day. And I would request all of you to let us celebrate that day. In these difficult times, this is the time we need to really dedicate ourselves to the babies. And care of babies in this times means taking care of our own self. And our own self, the most important part is the nurses. So let us dedicate. I would request all of you to conduct as many activities as possible on 12th of May as well. And this is the week is beginning today, and then we are beginning our activities today. And for that, we have an able leader in the form of our I should not say senior most, I should say the most vibrant neonatologist of our state, Professor PMC Nair sir, to lead us in this. And today's session will be led by him only. He's the primary faculty. We have an array of galaxy of faculty to actually lead in today's session. So please feel free to clear your doubts. You can further also, this is not the end of CNE, always is the beginning of training. It is not the end of training. You already had some online courses. We will have more courses. Please feel free to contact us, and you can contact through the WhatsApp group that is created, or you can contact here right now. The questions can be posted in the Q&A box, and you can clear all your doubts. So let us begin. I would not take any more time. With all your humble permission, this being a virtual CME, I have requested Sister Leena Paul, the nursing superintendent of Anandapuri Hospital, to physically actually light the lamp representing all of us. Is she around?
Yes, sure.
Madam, please come and inaugurate the lamp. And with that, with all your permission, we declare Nurses CNE open today. Thank you. So the lighting symbolizes, light is knowledge, we all know, and this symbolizes the beginning of the flood of information that is going to flow now. So let us go on with the CNE. May I request, yeah, please, stage is all yours, Kamala.
Thank you, Leena ma'am. Thank you, Manoj sir, for inaugurating this function. Now we invite Dr. T.V. Ravi, Head of Advanced Neonatal and Pediatric Tertiary Care Center at Ernakulam Medical College, to felicitate. He has expertise in neonatal intensive care and pediatric critical care. He was the president of NNF and IE Cochin branches in the past years, and an active organizer of NNF and Neocon sessions conducted in the past years. I invite you, sir, to felicitate this program.
So good afternoon, everybody. I wish to congratulate NNF Trivandrum, led by none other than Professor PMC sir, for organizing Neocon 2021, though virtually due to the pandemic problems we are facing. As you are aware, the nurses constitute the backbone of neonatal care, as they spend the maximum time with the precious babies we are treating. A competent and dedicated NICU nurse will be confident to make out even the subtle changes happening to the babies and handle them effectively. Hence, training of nurses adequately is the cornerstone of successful outcome. They need to be empowered to handle emergencies, as timely intervention is of utmost importance. I'm sure this workshop will go a long way in enhancing the skills of our NICU nurses. I wish the training all success and the conference a grand success over the coming 2-3 days. Thank you very much for having me here.
Thank you, sir. Thank you for those generous words of encouragement and support. Mr. mentioned that he is the president-elect for NNF Kerala for the next year. And now I invite Dr. Vishnu Mohan, Secretary NNF Kerala and Senior Consultant Neonatologist of Aster MIMS Calicut to offer felicitation.
Respected seniors and dear friends, a very good afternoon. It's a very happy moment to see such a wonderful attendance today. Thanks to PMC sir and team for the wonderful organization. When we took over as the office bearers in 2019, nurses empowerment was announced as one of the premier action plans of our action plan Newborn. And today I'm proud to tell we were able to conduct 25 physical workshops on essential newborn care in almost every district in Kerala, and also a national online nurses training module with 1,600 delegates from 25 states in our country. I'm sure Ravi sir and Dr. Nelby is going to carry forward this premier action plan, empowering the backbone of our neonatal care system. And I wish all delegates today a wonderful day of learning. Thank you.
Thank you, Dr. Vishnu. Thank you for those words. Now I invite Ms. Anupama, Nurse Manager, Department of Neonatology, Kim's Hospital, to offer her felicitation.
Good afternoon to all. I am Anupama. I am working as a nurse manager in the Department of Neonatology, Kim's Hospital, Trivandrum. First of all, I would like to thank the organizing committee for giving me a chance to say a few words in this occasion. When I started my career, I also thought that why we have to attend the CNEs and why we have to update ourselves. Later, I realized that clinical knowledge as well as theoretical knowledge are equally important to avoid errors in our professional life. Nowadays, majority of the people are living with the Google knowledge, and before admitting a patient in the hospital, they will search and find out all the treatment modalities, and they are approaching us with that knowledge. If we are not updated, we can't answer to their questions, and they are not satisfied with us. So we have to update ourselves. If we don't have adequate knowledge, we can't teach our juniors, and we have to update ourselves for decreasing errors in our professional lives also. We are so blessed in that we have a great team of doctors to teach us. Thank you, Dr. Naveen and the entire team for spending your valuable time with us for strengthening our knowledge. I'm taking this opportunity to welcome all the delegates and my dear colleagues in this great program. Make this as useful, clarify your doubts, and enjoy the program very well. And also, I am taking this opportunity to thank Dr. PMC sir, Dr. Manoj sir, Ravi sir, Kamala ma'am, and all the doctors for spending your valuable time with us for teaching us. Thank you.
Thank you, Anupama. Thank you for this apt words and for inspiring the nurses to update themselves. Thank you. Now I invite Dr. Hasina, Senior Consultant Neonatologist, NIMS Medicity, to deliver the vote of thanks.
Good afternoon. Am I audible?
Yes, Hasina.
Yes.
Okay.
Respected PMC sir, Manoj sir, Ravi sir, Dr. Kamala, Dr. Radhika, Dr. Vishnu Mohan, and all my seniors and colleagues, and all delegates attending the CNE. It's pandemic times and really trying one. All of you, please stay safe and help your patients stay safe. I would like to place on record my vote of thanks to our dear PMC sir, who still keeps the enthusiasm of a young kid in carrying on such programs and helps in disseminating the neonatal care knowledge. Dr. Manoj, President NNF Kerala, has been kind enough to inaugurate the session in spite of his busy schedule as a clinician and an office bearer. Thank you, sir. And I also would like to thank Dr. T.V. Ravi and Dr. Vishnu Mohan for their felicitations. Let me also thank a nurse manager of KIMS Health Neonatology Department, Mrs. Anupama, who has been working under Dr. Naveen Jain for a long 13 years. That will help all of you to know her efficiency and experience. She's a good friend of mine, and I thank you, Anupama. Let me also thank Dr. Kamala, Dr. Jyoti, Dr. Anju, Mrs. Ramya, who are all your faculties for the session. It would be a mistake on my part if I do not thank Dr. Naushidani for preparing e-brochure and the IT team of Anandapuri Hospitals for their excellent work. Finally, but most importantly, I place on record my sincere vote of thanks to all of you delegates who have registered in large numbers and are attending the session so as to improve your skills. Sharing knowledge is something which all of us should keep doing. And with this note, let me conclude and invite each and every one of you to attend the academic session. Please stay tuned till the end. Thank you.
Thank you, madam. With this, we come.
Can I make a session? Can I request all the panelists, all 12 of you, to enable a video so that we can have a stage photo? Unfortunately, we wanted everybody, but then in this, there is a technical glitch of taking panelists, the attendees photo. There are too many, actually, numbers are too huge. So, Dr. Jyoti, Dr. Ramya. Yeah. Okay. So, Anupama. Anupama, your screen is off. Please enable a video for a second. I think she is not there. I think we'll go on like that. Please hold on. Once more.
Sir,
Please.
I am here.
Yeah. Okay. Please hold on. Please hold on. Thank you. Kamala, it's all yours.
Okay, thanks. Thank you, madam. With this, we come to the end of our official inaugural ceremonies. We'll now begin with today's academic sessions. We have a total of 8 sessions, half an hour each, concerning the major topics in neonatology. And each session will conclude with a 5-minute question and answer session. So all the registered candidates can raise your queries in the question and answer chat box during the topic discussion. And due to time constraints, we'll be selecting a few of the raised questions at the end, and our eminent faculty will be more than willing to clarify the doubts. All the rest of the queries will be answered and updated in our WhatsApp groups. So first, our talk is on the 10 basic steps in newborn care by Dr. PMC Nair, sir. So Professor Dr. PMC Nair, Professor Emeritus in SAT Hospital and Honorable Consultant in Anandapuri Hospital and Research Institute and KIMS Hospital. Sir is the first neonatologist in Kerala, and he is well known worldwide for his research activities and contributions in the field of neonatology and for his enthusiastic attitude for endless teaching and learning process. I welcome you, sir, to begin our first session.
Good afternoon. Good afternoon, friends. it goes without saying that nurses are the real backbone of any neonatal care program. It is with this idea in mind, we are kickstarting the 27th state Neocon with a nursing CNE, for which we have obtained credit hours as well. Now let us start with the basic steps in neonatal care. The first and foremost is the good antenatal care. You should remember that baby has been in mother's womb for the last 9 months. So mother's health and nutrition is very important. Especially mother should have a varied diet. Second, safe delivery. The Lakshya program, which concentrates on the labor room quality improvement initiative by National Health Mission, gives a lot of importance for clean delivery practices. So in the delivery, we have the 6 cleans: clean surface, clean hands, clean razor, scissors are clean, clean cord type, and clean mother and linen. Proper resuscitation is very important. For that, we should have anticipation, preparation, as well as training for it. The resuscitation corner, especially it's the important duty of the nursing staff to see that all the equipments are kept ready, clean, and in working condition. Then hypothermia prevention, temperature regulation is very important. The delivery room temperature should be kept between 26 to 28 degrees centigrade and avoid hyperthermia at any cost. In the labor room, the temperature is between 26 to 28 degrees centigrade. The warmer should be switched on 10 minutes before delivery. We should have 3 pre-warm towels and no free float of air there. Nursery, the goal should be the admission temperature of the baby is between 36.5 to 37.5 centigrade. There are various methods to keep the baby warm, using radiant warmer, incubator, plastic wrap with cap, thermal mattress, increased room temperature, swaddling, and also kangaroo mother care. This is a preterm baby wrapped in transparent polyethylene without drying. Spring wrap can be used in the NICU also for keeping babies warm. This in the city hospital, babies kept in the radiant warmer. And incubator care is good, but the problem is it is very expensive, and also babies are kept more than 7 days, increased chance for infections there. Doing procedures inside the incubator is difficult, but good for the baby. Lying in ward, we should practice rooming in, co-bedding 24/7, baby covered, close to mother, away from the walls. Can have plastic bubble sheet, aluminum foil, etc. Cap, woolen mittens or socks can be used, and baby's temperature should be assessed by the hand test technique. That is the dorsal of the hand on the abdominal, and the abdomen is feeling warm, but the feet are cold. That means the baby has to be swaddled up. And suppose abdomen as well as feet both are cold, then that means baby has to be pre-warmed using the radiant warmer. This is not Kashmir or Switzerland. And in city hospital, baby is covered with cap, woolen mittens, and socks. Exothermic mattress, otherwise called the embrace, the phase changing material. You can keep the babies warm on this for about 4 hours. So ideal for transporting for X-ray, MRI, etc. Transport high-risk mother, ideal to transport to tertiary care center, because uterus is the ideal biological transport incubator. But the baby is already delivered, then transport incubator is used, or cover the baby with woolens, thermocol bag, box, or kangaroo care. This is transport incubator. And kangaroo mother care for babies less than 2 kg and not having any serious sickness. Baby in skin-to-skin contact, which will cause better temperature regulation, exclusive breastfeeding, enhanced survival, less infection, mother-infant bonding, and reduced hospital stay. Kangaroo position, that is skin-to-skin contact between the baby's front and mother's chest. Kangaroo nutrition is early and exclusive breastfeeding, and kangaroo support. That means kangaroo care can be given by dads as well. And coming to the basic care, identification tags to mother and baby is very important. I am a little bit strict on this issue because if you miss the identification tags, either the mother or the baby, you can end up with medical legal issues. So after cleaning and drying the baby, place the baby on the mother's abdomen, give to the mother for breastfeeding, and 1 shot of vitamin K is given. Umbilical cord care, usually it is kept open and dry and normally falls by 5 to 10 days of time. The stump of the umbilical cord should be inspected daily for any discharge or infection and kept clean and dry. There's no need for topical application of antiseptics unless indicated. And also take care to see that napkin is folded below the umbilicus. Clean the eyes after birth and once every day using sterile cotton swab. Avoid kajal to the eyes to prevent infection and lead poisoning. And delay bath for the first 24 to 48 hours. No vigorous attempt should be done to remove the vernix gaseosa because it provides protection as well as heat insulation to the delicate skin. This showing the vernix gaseosa. In our times, the attender used to take the baby out for a scrub bath and give the baby back, but this used to cause hypothermia as well as more infection. Skin care, baby skin is basically acidic, and so you should avoid adult soaps. Most of them are alkaline. Mild scented bars, maintaining the pH values better. Avoid emollients or baby lotions which are perfumed, which can cause irritant dermatitis for the baby. And change wet nappies immediately. All newborns should be weighed within the first hour of birth on a scale with at least 5 grams sensitivity and place either a single-use paper towel or a sterile cloth towel on the weighing scale beneath the infant. This is electronic weighing scale, and on the other side you see the infantometer and also taking the baby's head circumference. This circumference should be measured diligently because if you get a suboptimal head circumference, that is a pointer towards neurodevelopmental injury or delay. Neonatal sepsis is a nightmare for most of the pediatricians and neonatologists because most of the manifestations are silent, non-specific, stereotypes, missed up, overdiagnosed. Here you are seeing a small pustule on the neck of the baby. Yes, usually we are not worried about this, but if in a newborn, this can spread and become what is known as bullous impetigo. Here you are seeing scalded skin syndrome. So a very dangerous condition. Here the baby is very sick, staphylococcus scalded skin syndrome, and on IV antibiotics, and it's due to staphylococcal infection. Here you are seeing a redness around the umbilicus. This is the earliest manifestation of umbilical infection or ophalitis and pneumonitis. Here you are seeing the abdomen distended and redness spreading over the abdominal wall. That's called necrotizing fasciitis, or you have the baby with partially treated meningitis, where you get hydrocephalus, cerebral palsy, on-tube feeding, or the CT scan showing brain abscess. All this can happen from a small pustule. So the most important thing is to prevent sepsis, fastidious and obsessive hand washing. Soap, water, and common sense are the best disinfectants according to William Osler, the famous physician of yesteryears. Hand washing and with elbow-operated tabs so that you do not touch the sides unnecessarily. This is the hand washing technique. Most of you are familiar with this hand washing now, especially with the COVID-19 pandemic. So the red areas are the areas where the blood collects maximum. So coming to prevention of sepsis, hand washing is the most important step. Then clean delivery practice, clean area, avoid overcrowded areas, personal hygiene, avoiding those people with respiratory infection, diarrhea, skin infection, exclusive breastfeeding, and immunization are very important. Coming to breastfeeding, we all know mother's milk is the best for the baby, and colostrum, the first milk that is being secreted, is called as the liquid gold. It's intragastric immunoglobulin, baby's first vaccine. Baby sucking at the breast. The first picture you see poor attachment, baby sucking on the nipple. Second, you're seeing a better attachment, because most of the that areola portion should go on inside the baby's mouth, with the lips averted, especially the lower lip. And here also we see good attachment, and the other picture showing poor attachment. Here, say baby is not getting milk because of sucking only the nipple, so gets irritated and exhausted. And the causes of poor attachment can be use of feeding bottles, inexperienced mother, lack of skill support. Here showing the feeding bottle should never be used because it not only causes infection, can also cause what is called as a nipple confusion. Baby will be only sucking at the tip of the nipple. So how frequently should a mother breastfeed a baby? Healthy newborn baby to be breastfed on demand, that means every 2 to 3 hours, so that 8 to 10 times per day. And importantly, the mother should not omit any night phase because prolactin secretion is occurring more at night. Then adequacy of breastfeeds can be made out if the baby passes urine 6 to 8 times in 24 hours, goes to sleep 2 to 3 hours after the feeds, gains weight by 20 to 30 grams per day, and process the birth weight by 2 weeks of age. Issues in breastfeeding can be inverted flat nipples, sore nipples, breast engorgement, breast abscess, etc. This is using a syringe and the piston being pulled and causing the nipple to get inverted. We are quite comfortable with this double syringe technique for inverted nipples. You can use the rubber tubing or the IV set to connect between the two syringes, and the piston here is removed, and this is placed over the nipple and areola, and with the other piston create a negative suction and getting the nipple everted. Sore nipple causes can be incorrect attachment, mainly because of nipple sucking, frequent use of soap and water, or fungal infections. Problems in the baby can be sick baby, low birth weight baby, asphyxia, maxillofacial abnormalities, and here you see a baby with bilateral cleft lip and palate. And the lower picture shows the baby with micrognathia and some mucosal cleft in the posterior part of the palate. So this is a case of Pierre with sequence. Oral thrush is a very painful condition. Baby should not be fed with bottle or tube, and also we have to give nystatin or candid or paint. Low birth weight preterm baby, the 3 important points in caring is give warmth, prevent infection, and good nutrition. Baby is not able to exclusively breastfeed. We should give express breast milk by orogastric tube or by spoon or pilotite. Once expressing breast milk, which is ideal for especially primary gravida mothers, once the milk is expressed, it can be kept for 4 to 6 hours in the room temperature, in the refrigerator for 24 to 48 hours, and in the freezer compartment for about 3 to 6 months. Giving tube feeding as well as pilota feeding. And this also you see in the baby's skin pilota, and here the pilota is getting empty. But the important point is you have to keep the pilota, the gogarnam inside the baby's mouth till the baby swallows completely. Otherwise, what will happen is baby may aspirate the milk may come through the nose. As a young mother, the baby is only 650. That's happened about 20, 30 years back. And mother was so much worried, she used to run away to counsel her, take a seat and feed the baby. Now the child is almost 30-year-old adult. Now it's a small video on
the following video shows us alternative methods of feeding. Alternative methods include cup, of palate. Feeding by alternative methods is indicated in stable, low birth weight babies who are not able to breastfeed effectively. For palate feeding, you would require a palate, express breast milk or formula feed, syringe for measuring the amount of milk, and a piece of cloth to prevent spillage. Wash your hands before giving palate feed. Take a syringe, measure the required amount of milk, and pour it in the palate. Hold the infant semi-upright in your lap. Hold the palate so that the tip rests on the infant's lower lip. Tip the palate to pour a small amount of milk into the infant's mouth. Feed the infant slowly. Don't be in a hurry. Give sufficient time for the infant to swallow the milk before giving more.
So this point is important. The baby swallows. Otherwise, milk may come through the nose or baby may aspirate.
If there is significant spillage, give extra amount of milk to account for it. After feeding, burp the baby. Wash the palate and air dry it before next use.
Now coming to the 9th point, baby should be given hepatitis B at birth, oral polyvaccine and BCG. The mother should be taught that she has to play a key role in neonatal care, which starts even before the birth of the baby. As soon as the baby is born, start feeding. Exclusive breastfeeding till 6 months. Keep the baby warm, prevent infection, and identify danger signals for timely action and preference. Because time is precious, babies can become sick very fast. Now, what are the danger signals in a newborn? Refusal of feeds, increased drowsiness or poor activity, difficult or rapid breathing, abdominal distension, drooling of saliva, persistent vomiting or diarrhea, cold to touch, jaundice within 24 hours, a deep jaundice, not passing meconium first 24 hours and urine the first 48 hours, pallor off color look, bleeding from any side, seizures, high fever, etc. So I'll show some pictures. Most of them are innocuous ones. You don't have to do anything. Emilia is just an epithelial inclusion cyst or a keratin cyst, which is just fall off on the nose. It's seen in most of the babies. You don't have to worry. This is a capillary hemangioma. This is on the occipital region of the baby. This is otherwise called salmon patch or star bite nevus. And just leave it alone. Reassure the parents. It will increase for some time, for about 2 to 3 months, then it starts coming down. This is a strawberry hemangioma. If it is on delicate parts like over the eyes or over the nose, sometimes you require treatment. Otherwise, usually they regress and go. So treatment, we have propranolol, carbondazepine, laser therapy, etc. In the first picture, I'm showing a baby with extensive Mongolian spots. This can also happen. This is extremely normal. Disappear by 1 to 2 years of age. The second picture, I'm showing a baby with erythema toxicum, central white pattern surrounding erythema. So just an allergic reaction. You don't have to do anything. But coming to the third picture, there's a midline hemangioma, which is significant with a tuft of hair. So can be associated with spina bifida, operta, internally. Color of the baby, we look at it. The first baby is polycythemia, looking quite reddish. Then the second baby looking pale, jaundice. The umbilicus, here in the first here you're seeing a normal umbilicus, where in the other side you're seeing redness or erythema at the base of the umbilical stump. This can be an early sign of omphalitis or pneumocystis. You have to act. This again showing a peri-umbilical redness or erythema, which is the earliest sign of omphalitis or pneumocystis. Here you are seeing a pustule-like thing at the tip of the glans pages, whereas in this picture you see there is a pustule in the groin. So the first one is a harmless one. This is called as the Epstein pearl at the tip of the glans pages. This is again epithelial inclusion cyst only. It will just go off in a few days to weeks time, whereas this pustule in the groin should be treated. This is a picture of a baby showing cutis murmurata, mottling of the skin. This can be seen in congenital hypothyroidism, or the baby is extremely cold, exposed to cold weather, or a very sick baby. Yes, here you are seeing a sacral dimple, which can be normal in many people. whereas this one is a lumbosacral meningomyelocele. The meninges and the this rupture and the CSF is leaking out and can be a very dangerous condition. Lumbosacral meningomyelocele. Same bilateral raised erythematous satellite lesions on the groin, classical of candidiasis groin, and is common especially in the Arab countries because they groin here you are applying napkin for a long time. So the treatment is environmental modification, keep the area exposed and apply candid cream. Congenital Cannabis echinovirus, if detected early and can be modified accordingly. If you look at this baby is drowsy, some abdominal distension, and also everted umbilicus. Here you are seeing a classical case of congenital hypothyroidism or cretinism, large tongue, coarse facies. And with the neonatal screening programs, we are able to detect cases early so that any undue or unnecessary delay in growth and development does not happen. Here seeing the baby with microcephaly, receding forehead, and increased tone in the limbs. And this picture shows a hydrocephalus in a baby. So coming back to our presentation, the 10 important points are good antenatal care, safe delivery, proper resuscitation, prevent hypothermia, breastfeeding soon after birth, basic care, cord, skin and eye, prevent infection, low birth weight and preterm care, identification, danger signs and timely action, immunization followed. These are the most important 10 points for basic neonatal care. I think I have given a background upon which the other speakers can build up and make the session useful for the nurses. Thank you very much. I am open to questions if you have any.
So you can raise any queries you have in the chat box right now. We'll take some of the questions and sir will answer them. Sir, we have one question right now. So shall we take them, sir?
Yeah, okay.
So the first question is, what about vitamin K prophylaxis?
Yeah, vitamin K is given to all babies. Above 1 kg, we give 1 ml, and less than 1 kilo, or we just take it as preterm babies, 0.5 ml. That has to be given to all the babies. That is the current consensus. The main idea is to prevent hemorrhagic disease of the newborn. Any confusion? Because all the hospitals, I think, it's a written policy that we give as soon as the baby is born. Yes. What is the second question? Am I audible? Hello.
You are audible, sir.
Okay. And this one question I can read. What is that? Polyethylene. Polyethylene wrapping. That is usually you do for preterm babies. All babies less than 32 weeks, you are supposed to cover them in polyethylene wrap without drying in the labor room so that the baby's temperature will be maintained better. We use it in the NICUs also, especially under the radiant warmer to keep the babies quite warm in the micro environment. Yeah, the proper technique of parenteral feeding is place parallel inside of lip or middle part of the lip. No, actually, to the side of the mouth, not at the tip of the lip, to the side of the mouth. So, and keep it gently. I have seen people, what you call, bending it too fast, and too much milk may go in, and baby may not be able to swallow. So it may result in milk coming out through the nose and mouth and aspiration also. So it's very important to keep it on the side.
So if there are no more questions, we shall move on to the next session.
Okay. Thank you very much. Thank you.
Thank you, sir, for that wonderful and informative sessions. All other questions, we'll put the answers in the WhatsApp group. Next talk is on the initial steps of neonatal resuscitation program and bag and mask ventilation by Dr. Kamala Madam. Dr. Kamala Swarnam is the Senior Consultant Neonatologist in Anantapuri Hospital and Research Institute with professional expertise in the management of critically ill and high-risk neonates and advanced neonatal intensive care. I invite you, Madam, to introduce the initial steps in neonatal resuscitation and the mechanics of bag and mask ventilation.
Video stopping. Video stopping. A very warm good afternoon to all the delegates. We will go into the second talk in the CNE, the Neonatal Resuscitation Program, Initial Steps in Bag and Mask Ventilation. So even in the earlier times, the 18th century, obstetricians have recognized the need for tracheal intubation as part of neonatal resuscitation. In 1920, Bailey introduced simple rubber catheter to clear upper airways and stomach, and we are all familiar with the Apgar scheme introduced by Virginia Apgar in 1953. It took as far ahead as the year 2000 before we could publish a set of guidelines for neonatal resuscitation program. Then it was updated or revised in 2015 and 2020. So why do we need neonatal resuscitation? We know that birth asphyxia accounts for about a quarter of the 4 million neonatal deaths that occur each year worldwide. And we know that of the babies who are born, 90% do not need much help from us to make a smooth transition from intrauterine to extrauterine life. But approximately 10% newborns require some assistance to begin breathing at birth, and 1% will need extensive resuscitative measures. A little bit about the fetal physiology. We know that the fetus, while the baby is in utero, it is dependent completely on placenta for gas exchange. Our lungs, alveoli are filled with fluid, and you can see that these pulmonary arterioles, the blood supply to these alveoli, they are very constricted. And there is not much blood supply. Only 12% blood supply goes to the lungs in utero, in the fetus. But after delivery, what happens when the baby takes the first breath? The air fills the alveoli, and the air, along with the oxygen, reaches the blood vessels. And the PO2 increases, that is a stimulus for the pulmonary arteriolar dilatation. And subsequently, when the blood oxygen levels rise, the ductus arteriosus constricts and the blood flows through the lungs predominantly from the pulmonary artery to pick up the oxygen that is coming to the through each birth. So this is how the normal transition takes. So what can happen to interrupt this normal transition? So when there is birth asphyxia, what is birth asphyxia? Whenever there is a hypoxia leading to ischemia, it is combined, it is known as asphyxia. So when there is asphyxia, so it leads to a depressed respiratory drive, leading the baby to have apnea and hypoxia. There will be poor muscle tone, bradycardia, tachypnea, persistent cyanosis, and low blood pressure. If you look at this picture, you will know that when the baby is going into asphyxia, initially there is a period of tachypnea followed by primary apnea. Initially, the heart rate might be maintained normally, the BP may be normal. So once the baby is in primary apnea, then it is prolonged with no. So this is the right time for the intervention for the resuscitation. If we don't resuscitate the baby at this point, prolonged hypoxia can lead to gasping of the breath and secondary apnea. By this time, the heart rate will be coming down and down, bradycardia to zero, and the blood pressure will also be to severe hypertension and arrest. So that is why we do this NRP, NAS, and organization of resuscitation. So we need preparation before going into any birth, and we need to train our soldiers to do it in the right way. So NRP consists of the initial steps.
stuck ആയിരിക്കുന്നു. കണക്ട് ട്രൈ ചെയ്യണം അവരെ. ഓക്കെ ഓക്കെ ഓക്കെ. ഓഡിയോ ഇല്ല കേട്ടോ, ഓഡിയോ പോണില്ല, ഓഡിയോ കിട്ടുന്നില്ല.
Each and every member
It's come now. Okay.
And equipment share. So you need to make sure that all your equipments needed for resuscitation are ready, not only available, but ready to. It is functionality also need to check. It is always useful to keep a checklist or a equipment list near your delivery, so that every day one of the senior nurses in charge of the resuscitation, she needs to go through everything, make sure that all the equipments are there and it is functioning normally, and the expiry dates, everything she needs to check. And let me remind all of you about the universal precautions, and that is the 6 steps of hand washing. So once you anticipated the delivery, you should have the discussion about the umbilical cord management. And then latest NRP 2021 revision says that delayed clamp, there is enough evidence to say that delayed port clamp is very important for the child. So delaying the cord clamping till the umbilical cord pulsation stop, at least for about 30 to 60 seconds, both for term and preterm babies. For babies who do not require resuscitation, it will be very useful, and the advantages are it is higher. So during this time, it transfers around 60 to 80 ml of blood from the placenta from the maternal side to the baby, and this will give higher blood volume, higher blood pressure, lesser cardiovascular instability like hypertension, lesser chances of anemia and less transfusions, especially in preterm babies, and less chances of complications like intraventricular hemorrhage, lesser chance of necrotizing enterocolitis. And so you need to prepare in terms of place, personnel, and equipment. Your place should be warm. So you need to switch off your fan, AC, close the windows, and your warmer should be in manual with 100% heated output. And you should form the team assigned to brief them, hand washing 6 steps. Everybody should do before coming to the resuscitation warmer. And you need to make sure that all your equipment, availability, and functionality is easier to divide. To remember that the equipment needed for maintaining temperature, airway, breathing, circulation, like that. And I will give you a checklist in the PowerPoint so that you can make a checklist and paste it by the bedside, ready for resuscitation. In order to ensure thermoregulation, you need to have a labor room that is 26 to 28 degrees Celsius, and the radiant warmer should be switched on at least 10 minutes prior to the anticipated delivery. There should be at least 3 pre-warmed towels on the warmer, and there shouldn't be any free drops of air. This is the equipment checklist. So coming to the algorithm, unit of resuscitation algorithm proper. So the babies needing care can be divided into babies needing routine care, observational care, and post-resuscitation care. More than 90% of the babies will need only routine care. If the baby needs any resuscitation, then up to positive pressure ventilation less than 1 minute, the baby can be once after the resuscitation, that baby can be kept with the mother. But make sure that you monitor the temperature, heart rate, breathing, and color every 30 minutes or 2 hours till the baby is stable. But any baby needing resuscitation beyond PPV of 1 minute needs to have a post-resuscitation care unit. So initial assessment. Once a baby is born, we're looking at the baby and we're asking 3 questions. What are they? Is the baby term? Is the baby having foot tone? Is the baby breathing or crying? So you can see this baby. Baby's all flexed, crying, little bit sinused, flexed extremities. So this baby is having a foot tone. And this baby, you can see that baby is completely hypotonic. And baby has extended limbs and it's not breathing. So if the answer to all these assessment questions is yes, baby is term with good tone, breathing, and crying, you need only routine care. So when you see the baby coming out crying, follow the time. You can deliver the baby onto the mother's abdomen, dry, remove wet linen, cover and leave. By this time, it will be almost 30 to 60 seconds. So this much time you can give for delayed cord clamp. And once the cord is clamped, you can wipe the baby. You can take the baby and put the baby between naked baby between the mother's breast and give skin to skin care and initiate the breastfeeding at the earliest. But if the answer to the 3 questions is no, then you go to the initial steps. First, provide warmth, position the baby, clear the airway if needed for function. Right, stimulate baby. How do you do that? So positioning means position the baby instantly position. This helps in opening the airway. You can see that here the baby is having a slightly extended neck as if you're going to smell a flower, right? So this is the sniffing position, the kite position. This is the hyper extended position. This position can also cause blocking of the air. And here you can see that the neck is flexed. Here also the neck is block of air. So you need to put the baby in the correct sniffing position. Some babies who have a very prominent occiput, you might have trouble maintaining that mildly extended position. Here, now shoulder bone baby. You can put it under the shoulder to maintain the extended position. Coming to clearing the airway, no routine oronasophageal suction is needed for newborns. You can wipe the nose and mouth with a towel. If there are secretions, you can suction. So if needed only, you can do for suction. So clear the airway with, this is the bulb syringe, and this is the, as you can see, it's a Daly's mucus trap. You always have to suction the mouth first, because mouth is full of secretions. When you put the catheter into the nose first, it can stimulate the breath and the whole secretions can be aspirated. So always go for, you can remember this in the alphabetic order, M followed by N, O followed by N. So after suctioning the airway, or you can use the electrical suction, you make sure that the suction pressure is between 80 to 100 millimeters of mercury. Always use the appropriate suction catheter, around 8 to 10 French catheters, or if you have thicker secretions of the thick meconium, you can go for 12 French catheters. And make sure that you don't do prolonged suction. It will produce laryngeal spasm and it can be counterproductive. It can induce bradycardia. Dry the baby thoroughly, remove material and reposition the head, and stimulation. Coming to, so if with these factors, the baby is not starting to breathe, cry, then you can go for stimulation. The stimulation can be done by briskly rubbing the back. We can just rub the naked back, or with the towel you can rub the back. That will stimulate the baby. Earlier we used to say flicking of the toes or rubbing the back. Now flicking of the toes is no longer recommended. That can destabilize the baby. At the end of the initial step, you re-evaluate the baby at the end of 30 seconds. So what are the two things that you look at the end of 30 seconds? Respiration and heart rate. These are the two vital signs that you look at. So if the baby is still having apnea or gasping, or if the heart rate is less than 100 per minute, you need to go to the next step. That is the positive pressure ventilation. And you have to know that heart rate is the most important and sensitive indicator of response to each intervention. So if you're doing an adequate job, or if the baby is responding well to your initial steps of resuscitation, you can see that by the increasing heart rate. So how do you look at the heart rate? So you can earlier used to hold the umbilical cord and feel the pulsations, but it is not a very reliable marker, because umbilical cord pulsations can cease or pulsations can stop. So no longer measuring heart. Always the best method is by doing a pre-lead. This is the current recommendation. You can always use a stethoscope if you don't have the facility to for a pre-lead. But it's always better for babies in need of resuscitation to go for a pulse oximeter and a 3-lead ECG. That will give you the oxygen saturation and the heart rate in real time when you're doing the resuscitation. So the baby is born, you have done the initial step, and you are re-evaluating, and you have found that baby is not breathing or have apnea or heart rate is less than 100. So immediately initiate the positive pressure ventilation, and the positive pressure ventilation should be initiated in a baby requiring resuscitation in the first golden minute. That will give you a very good prognosis for them. To emphasize the point, the importance of avoiding delaying the initiation of ventilation. Okay, so what is positive pressure ventilation? So when we talked about the fetal physiology, we said when the air goes into with the first breath or try, the air enters the alveoli. Then the increasing and the oxygen exchange happens. Oxygen enters the blood vessels and increase PO2. So these are all needed for smooth transition or normal transition. So the first and foremost step will be the ventilation of the lungs. To open up the lungs, make sure that the oxygen reaches the alveoli and the pulmonary arterioles. So ventilation of the lungs is the single most important step in the cardiopulmonary resuscitation of the compromised bone. And the indications, as we said, is baby not breathing or apnea or gasping, and heart rate below 100 beats per minute. And another indication, saturation remaining below the age-adjusted margin. So what are the devices that can be used for PPV? A self-inflating bag or your common ambu bag. A flow inflating bag, not very commonly used, mostly by anesthetists. And the T-piece resuscitator. More and more units are more comfortable with using a T-piece resuscitator. So we will come to the 3 devices. This is your ambu bag. Always make sure that it is working normally. All the parts are properly connected. There is no wrench in the bag, and the pop-up valve is working. Everything is working before you go into the delivery room. And with the while delivering positive pressure with the ambu bag, and you can give only the peak inspirated pressure, but there is no the PEEP. So PEEP is the one that keep the lungs inflated. So that is one drawback of the self-inflating bag. But you can give almost 100% oxygen when you are connecting the ambu bag to an oxygen reservoir with around 10 liters of flow and with oxygen source with a 10 liters flow and a reservoir. This is the TP's resuscitator. So advantage of TP's resuscitator is you have more control over the pressures and the inspiratory time. So you can set the PIP and PEEP index. So PIP is the highest pressure that you are giving. PEEP is when you release the pressure, that is the peak and expiratory pressure. So these two are very helpful in preventing the volume trauma and baro trauma. And other features are if you hold it for a little bit more time, you can have a more prolonged inspiratory time that will be helpful in initial ventilation, initial opening up of the lungs. And this is the flow inflating bag of anesthetic bag. So these are the how you differentiate it. These are the advantages and disadvantages of self-inflating bag and PP's resuscitator. So if you look at this self-inflating bag, so the PIP and the TI depends on how hard and long the bag is squeezed. If you want to give more volumes to press deeply, and if you want to give more pressure, you can give it a sharp press to give it an increased pressure. And so PEEP cannot be given, and only if you add a PEEP valve, you can give PEEP through a self-inflating bag. So you can't give CPAP or free flow through an ambu bag. And you have safety features like a pop-off valve. As we mentioned earlier, if you go beyond 35 to 40 centimeters of water pressure, there is a pop-off valve which helps in the baby getting an increased pressure and preventing the bad trauma. If the TB is resuscitated, you need to have a proper seal. You can set the PIP and PEEP manually. You can adjust the FIO in some TB's resuscitators with blender. And there is a maximum pressure relief valve, pressure, and also pressure gauge. So you can adjust your PIP and PEEP with the TB's resuscitation. You can always start with room air resuscitation. For term babies, term babies and babies more than 35 weeks, always start with the room air resuscitation. That is, you can have an ambu bag without connecting the O2 and without a reservoir. That alone is sufficient to start resuscitation for a term baby. And for a preterm baby, always start with around 21 to 30%. So you need a saturation probe onto the right hand of the baby to give us a guide regarding how much oxygen you should give. And you can adjust the FIO depending on the SpO2 monitor. And once you go from PPV to chest compression, always remember to increase the FIO to 100%. And you need an oxygen blender, pulse oximeter, and a 3-lead ECG if possible. So this is the targeted pre-ductal saturation after birth. And you must notice that the 80 to 85% saturation is only attained by around 5 minutes. So you don't expect an 80% in less than 5 minutes. Don't go on heighten your oxygen when you see a 70-75 oxygen at 2 to 3 minutes. And by only 10 minutes, you will have an 85 to 90% saturation. This is your ambu bag. And when you connect the oxygen reservoir, connect the oxygen tubing without a reservoir, you are delivering around 40% oxygen. But oxygen is connected with the reservoir, you can give around 90 to 100%. Safety features we have already mentioned. Apply the mask correctly, cut the chin with the mask, and then cover the mouth and nose. And always use the appropriate sized mask. You should cover from the tip of the chin up to the root of the nose. You shouldn't be applying pressure over the eyes. So this is the correct position of the mask. This is the incorrect position. You can see that it is overshooting at the chin. So there will be a leak here. This is the too small mask. And you can stand at the head bend or by the side to give PPV. There shouldn't be a leak. Apply the mask properly. The EC clamp technique. You can see that by holding the mask with the thumb and the forefinger, you're holding the mask with the C. And with the rest of the fingers, you form a P. You form an E around your jaw. And make sure you don't press the soft tissue of the neck is your fingers. You might obstruct the airway while you are doing that. So hold the mask in the right place, as I said. Mask on the face with the C, with the middle finger, and with the thumb and index finger, and with the rest of the fingers form an E and hook it around the around your jaw. And the frequency of back-end masturbation should be around 40 to 60 breaths per minute. So you have to remember doing like squeeze 2, 3, squeeze 2, 3. When you say squeeze, you press the ambu bag, and when you say 2, 3, you release the bag. Like that. In the speed that you are saying squeeze 2, 3, if you are doing it every second, then you are delivering breaths at 60 breaths per minute. When you take around 1 to 1.5 seconds, you are giving it more slowly, around 40 breaths per minute. So you can adjust the speed by saying the squeeze 2, 3 method. So you should have an appropriate size bag, minimum volume of around 200 up to around 750 ml. Term babies need only 4 to 6 ml per kg of tidal volume, so that you should give around 10 to 25 ml with each ventilation. And most important indicator of a successful positive pressure ventilation is rising heart rate and chest size. Other indicators include improvement in oxygen saturation. You can auscultate to find out whether the breath sounds are equal and adequate bilaterally. Color and tone also improves if you have a good positive pressure, if you are doing an effective positive pressure ventilation. So always after starting your positive pressure ventilation, reassess after 15 seconds or after 5 to 10 breaths to make sure that your heart rate is improving and there is adequate chest size. If it is not happening, go to the ventilator corrective steps. Ventilation corrective steps is MR SOFA. So what is MR SOFA? You do the mask adjustment, the leak around the face mask, inadequate seal. So reapply the face mask and do a proper easy clamp. Reposition whenever the baby's neck is flexed, it can block the airway. So reposition again. If needed, use a shoulder hold. Then suction. If there are secretion, you can apply suction. You can turn the head to one side and give suction. Open the airway. Usually, you can with the tip of the mask can open the airway. Sometimes the baby will have a clenched mouth. Sometimes there may be choanal atresia or tongue falling back with Peary-Robbins syndrome. So in these conditions, you might need to apply a oral airway to keep the mouth open, and you can apply your ambu bag mask over the oral airway. If these things don't work, you need to increase the pressure, how much pressure you are giving with the mask. As I mentioned earlier, you can give a deeper squeeze or a sharp increase in the pressure of the squeeze to give increased pressure. And with the TP's resuscitator, you can always dial the control of the inspiratory pressure control to increase the pressure. So if these measures doesn't work, you need to go for alternate airway like endotracheal intubation of LMV. So laryngeal mask airway or LMV can be used in babies more than 34 weeks and more than 2 kg, and it can be used when tracheal intubation is not feasible or unsuccessful. Always remember, if your bag and mask ventilation are continued for several minutes and if the stomach is distended, it can interfere with the lung expansion. So insert an orogastric tube, a size 6 to 8 French tube can be inserted to decompress the stomach, aspirate the syringe and leave it open to the air. And when do you stop bag and mask ventilation? When the heart rate is above 100 per minute and and spontaneous breathing is established, you can stop bag and mask ventilation. Even after baby has spontaneous breaths, the baby can still have cyanosis or labored breathing, like grunting, subcostal intercostal fractions. Then you need to give additional supplemental oxygen or CPAP. Then supplemental oxygen can be given with oxygen mask, low inflating bag and mask, TP's resuscitator, or an oxygen tubing held close to the baby's mouth and nose. And free flow cannot be, and remember, it cannot be given by a bag and by the ambu mask. You can't hold an ambu bag mask close to the nose and nose to give free flow. So these are the methods to give free flow mask, low inflating bag or TP's resuscitator. So this is the 2021 algorithm. And if we finish with the PPV and bag and mask ventilation, if you have any queries, I'd be happy to answer after the session starts. Let's talk with you.
Thank you, madam, for that very informative discussion. So we found that all the queries are being answered in the chat box itself. So please continue to be interactive and we'll move on with the next session. So next we have a discussion on the drug preparations and administration in neonatal ICU by Professor Ramya, madam. Professor Ramya UR is the professor and head of Department of Child Health Nursing at Sri Gokulam Medical College. I invite you, ma'am, to discuss regarding the drug preparations and administration in NICU.
Good afternoon to all. Myself, Ramya, working as professor and HOD Department of Child Health Nursing, Sri Gokulam Nursing College, Vanyaramuda. Today, I'm very happy that I can be a part of this nursing CNE organized by Neocon, Kerala State 2021. And I'm very thankful to Dr. PMC sir and Dr. Kamala ma'am to making me a part of this conference. Thank you, sir, and thank you, ma'am, and all other organizers and coordinators of this nursing CNE. So my topic for today is drug preparation and administration in NICU. So actually it's very vague topic and it is hard to complete within 25 to 30 minutes. So that I have decided to include some general guidelines and considerations while preparing and administering medicines in NICU. Okay, so next we move on to why this is important in neonates. Okay, so in NICU, and it's a most challenging job for the NICU staff. Why? Because the medication error rate or the incident rate is 8 times higher in neonates when comparing with other population or other age groups, because of their different physiology. That is, neonatal physiology is different. They have small, fragile body type, and also their immature organ system, then clinical illness, then lack of specific medications for neonates, then unavailability of neonatal drug concentrations, and system and environmental factors, because workload of the staff, then staff shortage in an ICU. So all these are the reasons for incidence of medication error in neonates. Okay. Moving on to what is medication error. So it's actually a preventable event that might cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional. Actually, the medicine is under the healthcare professional's control, but because of the inappropriate dose calculation or wrong practice or improper weight checking or poor drug concentrations, poor dilution, so we are making mistakes that may cause harm to the neonates. Okay, actually it's preventable one, but still, because of our irresponsibility, because of our mistake, that harm the neonate. Okay, so that is medication error. So this error can be happen at any stage of medication process. As you all know, medication process, it's having mainly 4 stages: prescription or transcription, then preparation, the administration, and monitoring. So the error can be occur at any of this stage. Okay. Now, moving on to common neonatal errors. So what are the common neonatal errors that can happen? So the first one is dose calculation error. It's the most frequent error that happens in NICU because the neonatal drug concentration is totally different with the other age groups. Okay, so it's very difficult, and the staff nurses should be knowledgeable and they should have a proper practice on drug calculations, and they should be aware about all the formulas of all the neonatal formularies. Okay, so if they doesn't know that, that may cause error, medication error. Then incorrect expression of the measurement unit. Usually the expression of the measurement unit is of mass, not volume. Okay, and expressed in milligrams or in micrograms, not in grams and kilograms. Then wrong decimal point placement, that is instead of 0.01, if you're administering 0.1 mg, so there is 10-fold higher dose for neonate and anything can happen. Then wrong neonatal weight recording. So if your system is not following or maintaining a proper weight recording system, that may affect the drug calculation or drug concentration. So okay, error can happen. Then mistaken administration rate, route or timing. Then incorrect dilutions. Okay, so usually we'll take 5% dextrose, 10% dextrose, normal saline for dilutions, but some of the drugs cannot be diluted in this solution. So that should be familiar. And then wrong settings on infusion pump. All the working mechanism of infusion pump must be practiced by every NICU nurses. Okay, so this is a initiative that can be taken from NICU in charges. They can give a training, proper training in the initial period of the NICU posting itself. Okay, then the missed doses. These are the common neonatal errors that can happen. Then now it's about the stage of medication process. First one is prescribing or transcription. 98.5% of errors in the NICU occurred in prescribing phase. So this is a combination of the NICU nurses, neonatologists, and the pharmacy people. Okay, so here the prescription phase, the errors can be from the pharmacy side or from the neonatologist or from NICU staffs. Okay, so here if you are establishing, the chief neonatologist of NICU is establishing, and if they are preparing a proper drug protocol, neonatal drug protocol, administration guidelines and infusion rate guidelines, then it will be safer for all the neonates, those who are admitted in NICU. Then use of CPOE system with an approved neonatal formulary, prompts and clinical decision support to decrease and reduce the errors. So use of CPOE system. What is CPOE system? It's a computerized physician order entry system. Most of the hospitals now, they are following CPOE system. And it reduces the medication error because the physician themselves prescribing the medicines from the computer system, and they'll choose the drug, the dose, the route of administration, everything will be entered into the system, and so that it is easy for the nurses, NICU nurses, to administer and preparing the drugs for the neonate. Okay, then electronic generation of medication. Not only electronic generated medication administration records, manual medication administration records can also be maintained, and it's also an important thing that will help the NICU nurses to make the neonates more safer. So this is computerized physician order entry system. Here it includes all the medications list and doses, route, everything can be entered in the system itself. Okay. Then this is medication administration record. That is, this first one is manual records, and the second one is electronic generated medical administration record. Okay, so this the first one you have to fill it properly, and the second one electronic computer system. You can access the computer for electronic generated medication administration system. Okay, then prescribing principles. Some of the principles that includes medication chart, preparation of medication chart, which includes gestation at birth, then date of birth, current body weight, basis for the dose calculation, etc. Then prescribe practical doses for easy measurement and administration. So if you have that drug formulary, or if you have drug protocols, it is easy for measurement and administration. Then prescribe dose in units of mass, that is not in unit of oleum. Okay, so not in milliliters, liters, but in micrograms or milligrams. Okay, that is mg, 150 mg per kg per dose, then 0.1 mg per hour. Okay, so like that. So this is the unit of expression. Then follow general principles of drug prescribing of medicine, that is generic, route, dose, frequency, duration, etc. don't use brand names. Okay, then use standard prescribing intervals and terminology, standard medication terms and abbreviations, route of administration. So for route of administration, dose, frequency, for everything we have standard abbreviations names like QID, that is for 4th hourly, and then PRN, then NEB. Okay, so like that we have IM and intramuscular, you can write IM. And if you're giving any medicine daily, that time you have to write in fully. Okay, so daily, that you have to write it in full, daily. Okay, then limit verbal to medical face-to-face and telephone orders unless it is a medical emergency situation. So please avoid verbal orders. Always follow written orders. Okay. Then next is preparation of medication. So preparation of medication is also important because it's the correct choice of medication. Okay, so here the NICU nurses, they have to pay more attention in the appropriate dose and interval based on the factors that may affect the pharmacokinetics and pharmacodynamics of the drug. Okay. So here you have to follow the standardization and labeling. So standardization and labeling is very, very important in preparation of medication. So what is standardization? Your system should have a proper standardized protocol or guideline. Okay, and this can be get it from the pharmacy or from chief neonatologist. Then establish one standard neonatal drug concentration for each injectable and oral medication, and NICU nurses must follow the standardized drug protocol. Okay, so all the injectable and oral medication should have a standard neonatal drug concentrations, and the NICU nurses should be familiar with that. Then can stimulate demand for manufacturers to get the commercially standard solutions, prepared solution. Already prepared solutions can be get from the manufacturers, but for neonates it's quite less. Okay, so for neonates we have to dilute we should know the drug concentrations and everything, so it's difficult to get from the manufacturers. And then labeling principles, here you have to focus on LASA drugs. LASA drugs, LASA. LASA drugs means look-alike and sound-alike drugs. There are so many drugs with with confusing names. Okay, that is dobutamine, dopamine, vincristine, vincristine and vinblastine. Then almodipine, nifedipine. So like that. Okay, so how can you prevent the confusions of LASA drugs? You can establish a list of drugs like that. Then you have to segregate and you have to store it in separate places. With labels. And then you can use Tolman lettering or mixed case lettering. That means if you are using fentanyl and fentanyl, the first 3 or 4 letters should be in small caps, and then you can use capital letters. Then subfentanyl, you can use SUF as small, and ENTNAIL is as caps. Like that you can label, and you can reduce the confusions. Then label all containers, that is bags, syringes containing medicines. So if any bags or syringes with any medicines, you have to label it properly. Then labeling injectables, that is another thing. So labeling injectables, the nurse who is drawing the medications from the vial or the ampule, the rest of the medication should be labeled and kept in the refrigerator. Okay, then include all the labeling part includes some of the components that are patient name, total amount of active ingredient, then total volume of fluid in the container, concentration, diluent, date and time prepared, date and time of expiry, signatures of both persons responsible for medication administration, then route of administration. Okay. Then labeling administration of lines. So that's also important. So because neonates may have IV lines, that is central line, UAZ lines, that is umbilical artery catheterization, then central lines. Okay, so you have to label the starting point and also the end point of the line. Okay, so you can use pre-printed medicine labels. If there is any unavailability of pre-printed medicine labels, you can use generic medicine labels also. Then include route, day, time, and line when it was commenced. Okay, so that will be helpful for the next staff who is handing over the neonate. Then administration of medications, many drugs used. And so after preparation, we come to administration of medication. So while administering a drug to a neonate, it is very important to confirm the dose, confirm the calculated dose. So double checking is very, very important, and also the route of administration that you are selecting for administering the drug is important. Okay, so it's completely based on the physician order. So in this stage, you have to be more clear about medication safety. So in order to save the medication, you have to follow 6 rights of medication. That is right patient, right drug, right time, right dose, right route, and right response or documentation. It's very, very important. I'm not going in detail because you all know this, what is all these 6 rights. The next is double checking. I have already mentioned that the double checking is very, very important. 2 independent nurses can be a part of this double checking. The first nurse, those who are looking after the neonate, can calculate the drug. At the same time, the another independent nurse will also calculate the drug, and again they can come together and verify and confirm this is the exact dose. Okay, so this is double checking. Then the drug delivery is based on whether you have delivered the drug prescribed order, and dose calculation is correct, mixing with any diluents, the dilution is proper, method of administration is okay, and the standardized IV drug concentration you have followed, and whether you are using a smart IV, completely working IV pumps for infusion. Okay, then double checking, I have explained it. Then now it's about after medication safety and double checking. It is medication chart, preparation of medication chart. In most of the hospitals, they have a format, a common format for medication chart. If you have not having that format, you can use a national medication chart format and all. The one thing is you have to add all the components like name of the drug, indication for use, route of administration, instruction how to administer, steps to follow if adverse drug reactions or accidental overdose is suspected. Okay, here I am giving one sample that after getting the PPT you can refer. Okay, so date or month and the name of the drug, the dose, and the indication, the frequency, and what actions to be taken if any higher dose or overdose is suspected. Okay, so everything should be monitored. Then now it's about route of administration. So route of administration, it's a monogram, color monograph. So here different route of administrations are available for neonates: oral, intravenous, intramuscular, peripheral, then umbilical, then inhalation, ophthalmic, topical, nasal, otic, rectal, buccal. So all the route of administration is preferable for neonates also, but you have to follow some local protocols for all these, each type of routes. Okay, so please go through this monograph also. I have mentioned some of the protocols, guidelines while using intramuscular, while using oral administration and all. And some specific points for oral administration. Prepared and administered using only oral syringes. You can use orogastric tubes and nasogastric tubes. Then place the medication into the center of the barrel. If you are giving through oral syringes, you can place the medicine in the center of the barrel of the syringe. Okay, so it is for easy administration. And then administered into if the neonate is breastfeeding, then you can give along with the medicine can be given along with expressed breast milk. Okay, then another one important thing is document the color of the emesis or residual material, whether there is any color change because of this medicine. Okay, then intramuscular administration. So the first thing is the site location. Anterolateral thigh is the actual site of intramuscular injection. So how to locate the site, I have given in this diagram. So you please go through that and you can use a syringe of 22 to 25 gauge needle and use 1 ml syringe for oral administration, and if your infant is weighing less than 1500, you can inject an oleum of 0.5 ml maximum, not exceeds more than 0.5 ml. And also you have to hold the needle at 90-degree angle in the outer thigh of your newborn. Then intravenous administration. So intravenous means you are directly given into the bloodstream, and you can keep in 2 ways, that is through pump and IV push. Okay, so here it interferes with some factors, that is dosage, oleum, IV flow rate, and injection site you are selecting. Okay, and the cannula size is depends on the neonate and how long you have to keep the cannula inside. Okay, and the peripheral venous access is the most preferable. Then central lines and the UAC are also given for the neonates. So cannula sizes may range from 22 to 26 gauge, most preferably 24 and 26 gauges. Then IV cannulation sites, it's given here. You can go through that. It's intravenous administration. So while intravenous administration, some of the drugs you are not supposed to give through UAC lines, umbilical artery catheterization. That is mainly vasoactive agents like dopamine, dobutamine, adrenaline. So all these drugs should not give. Please avoid and be cautious while administering this through umbilical artery catheterization. Then drug incompatibilities. So incompatibility reactions should be monitored. Okay, so drug solution. So incompatibilities may happen with anything. Okay, so drug means with along with amikacin, please avoid phenobarbital and phenytoin, and also the drug solutions. So some of the drugs may not be diluted with 5% dextrose or 10% dextrose. So that type of medicine should be noted. Then continuous infusion of vasopressors should never be interrupted. It should not be interrupted, and you are not supposed to give by bolus. Okay, and some of the drugs like sympathomimetic amines should be avoided. That means dobutamine. So these drugs may activate or stimulate noradrenaline and adrenaline. Okay, so that may cause adverse reactions in newborns. So these are all common under potent medications. Okay, it should not give continuous infusions. Then push injections. So what all the guidelines should be followed in injections by push. Okay, so that administers small oleum, and the medication should be given for a duration of 1 to 2 minutes. Not more than that, and opioids and sedatives should be given with great care. Then pump, I have already mentioned that what is the importance of knowing the working mechanism of pump, infusion pumps. Okay, so please go through it. Infection control, another important area. So medication safety, then medication chart, double checking, then infection control. So it's very important, as you all know, the newborns, they are very prone to develop infections. So hand hygiene is important, cleaning areas used in the medicine preparation is important, sterile techniques for administration of medicines via central lines and total parental nutrition, single vial access or single patient access following local procedures, then single use of consumables, screening of infusion device, all these things should be kept in mind. Then next, the last stage, that is monitoring. So after medication administration, it is very important to monitor what are the adverse reactions happen. Okay, so what may be the adverse reaction? So you have to give a close monitoring to the newborn. Okay, so the NICU staff must be educated with what all the adverse reactions may happen within this particular time period for this specific condition. Okay, so like that, you have to make them more knowledgeable and more educated. And the bedside nurse who is constantly with the sick neonate must be familiar with the adverse effects of all medications that are given. And here some of the standard guidelines for medication procedures. All medications prescribed for an infant will be ordered by a medical officer, that is chief neonatologist. You are not supposed to administer any drug without physician order. That All medications prescribed for an infant will be ordered in weight per kilogram of body weight, not by fluid volume. That is unit of mass, microgram, milligram, then not milliliters. Okay, and some of the drugs like calcium gluconate, sodium phosphate, Fergan, pentavite, and statin, exceptions are there. Then all medications prescribed for an infant will have the frequency ordered in hours, that is 6 hourly means QID, and then standard abbreviations and terms are available. So based on the policy, you can refer it and you can use that. Only standard abbreviation should be used. And prepare a proper medication chart. It is important, and the prescribed dose should be accurately measured. Then if you want to cease any medication as per the physician order, you have to draw a diagonal line from the top side to the bottom side. It's important. When changing a dose or frequency of any of the drugs, you have to again. Then each medication will have a printed label that we have already mentioned. The labeling principles, the name, gestational age, date of birth, and unit number should be there. And the medication order should be legibly printed, and it should contain all these informations. Okay. And then NICU medication protocol manual should be there. The generic names of medication, dosage, dilution, preferred route, side effects, compatibility, everything should be prepared and kept in NICU. Then when alternative routes like oral or parenteral, the range of dose, that is 5 to 10 mg, if the physician is ordered like that, if what you are giving, what dose you have given, what route you preferred, that should be reported, that should be documented. When topical medications are given, you have to locate the specific area where you applied. Then all medication must be given in a slow infusion, commenced as soon as possible after being drawn up. Oral medication can be left to give. So if you want to give oral medications, but the baby is getting feed after 30 minutes, you can wait for 30 minutes, and along with the feeds, you can give the medication. When drawing up and giving IV or UA medication, aseptic technique should be followed, and one medication at a time, more than one medication at a time, it should be labeled properly. Okay, then if you are giving any PRN medications, if necessary, okay, then you have to document the reason why you have given and what result obtained. Then if the medication is not given, the reason must be documented. Medication may be added to infusion fluids. So if infusion fluids is there, then you can add one additive to each burette, syringe or pack. Not more than one additive should be added. Then no medication to be added to pack of blood products or blood or parenteral nutrition. You are not supposed to give any medication along with the blood transfusion or parenteral nutrition. Then medication may be added through sightline as close to the cannula as possible, and non-Leo compatible enteral syringes can be used because that will be more preferable. So Leo compatible enteral syringes, that may lock it. Okay, so the non-Leo compatible enteral syringes can be used for oral doses. And that's all about the stages of medication process. I think you are clear with all the stages of medication process where a medication error can happen, so that what preventive measures can be taken. Now it's about commonly used drugs and dilutions. I have included some of the drugs like phenobarbital, phenytoin, then calcium gluconate, then adrenaline, dopamine, diazepam, fentanyl, insulin regular, morphine, and then prostaglandin, everything. So you can go through each drug and you can see what is the infusion rate, prescribe the dose, and what precautions you should take for each medicine. So the coordinators of the CNE, they'll give the PPT, and that time you can go through that. And if you have any clarifications or any doubts, you can give your questions. Okay, thank you so much. Okay.
Thank you, ma'am. Thank you, ma'am, for those very fundamental yet very important aspects in neonatal drug therapy. So we have two questions in the Q&A chat box. The first question is, in nursing practice, the rule of medicine providing is a triple times checking. So does that mean we have to check the drugs before going to the near the child, after going near the child, and before administering the drug?
Yeah, yes. Triple checking is most important thing that you have to follow. But double checking in case of general, case of general cases you can go for double checking. But in critical cases, as like neonate with chronic illnesses and all, definitely you have to follow the triple checking. Yeah, it's compulsory.
Thank you, ma'am. And one more question. Is there any formula for a drug calculation in neonatal drugs?
Yeah, of course. There are so many formulas are available, but because of this time constraint, we cannot go each and every drug and its formulas and all. But I request the nursing CNE, if you are having the next step of CNE, you can include the topic that is drug formulas in neonatal or in NICU. So that time we can go in detail with each and every drug, and we can calculate the dosages with the formulas. Thank you.
Thank you, ma'am. So next we have the discussion on infection control and sepsis prevention in neonatal ICU by Dr. Indumati Madam. Dr. Kristen Indumati is the senior neonatologist in SUT hospitals, and she is well known for her expertise in preterm and low birth weight baby care and for the holistic approach and support given for the neonates and their families. I welcome you, madam, to enlighten us regarding the infection control measures to be followed in NICUs for sepsis prevention.
Good evening, everyone. I thank the organizers for giving me this opportunity to talk about a very important topic in the ICUs, which is infection control and sepsis prevention. We know, as we are health workers, doctors and nurses dealing with the smallest of babies, we know how important it is to avoid infection. And therefore, this topic is very important. What is infection control prevention? It's a set of practices designed to reduce the transmission of all communicable diseases among the patients, the healthcare workers, and visitors in the hospital setting. We also know that simple actions of infection control can make big changes. Like hand hygiene, once it was introduced, we know that how it has reduced the infections. Now, let us have a small word or talk about the pioneers in infection control. Way back, it was Sushruta, the father of surgery, 400 to 800 BC, who wrote a treatise on surgery, and he used to use fumigation techniques, and he used to also sterilize the instruments. Then we have Semmelweis, who talked about importance of hand washing, though he was not accepted by his peers initially. Joseph Lister, the father of modern surgery, he talked about nosocomial infections and how to prevent them. And he laid down the protocols for infection. Now we know in a hospital setting, we have a variety of organisms. And now added to the list is our COVID-19. Now, how to go about preventing these organisms invading our patients? Among the emerging pathogens, it is in the developed world, we have the gram-positive, which account for 45 to 75% of bloodstream infections. In the developing world, we have the gram-negative organisms. Both places, we have the Candida fungus as an emerging pathogen. Healthcare-associated infections can be divided into bloodstream infections, respiratory infections like ventilator-associated pneumonias, urinary tract infections, and skin infections. And the modes of transmission are by contact, droplet, or airborne. Now, the basic elements of infection control are the same in adult or the neoclassics. First of all, we have a risk assessment, and then we have the hygiene and control measures. In the risk assessment, we need to know the patient. And here it is the newborn. Appropriate interventions and barriers should be put in place for the newborn. In the newborn, we have to look at the risk factors. It could be
Low birth weight babies, they could be premature babies, and the severity of illness may be there. Newborns have an immature immune system, and we know that the skin is permeable to microbes easily. Now, the WHO has set up the standard precautions to be followed by healthcare facilities. We will be looking at each. First of all, and most effective is the hand hygiene. Each unit or each hospital area should have a proper hand hygiene area and provision of elbow taps, provision of proper solutions for hand washing and hand rub is important. Avoiding jewelry, nail polishes, and cutting the nails is important also. It is not only important to wash the hands before entering the ICU. One should know that there are moments of contact with the patient where we can transmit the microbes. And these moments are given as 5 moments of hand hygiene, which you can see in the picture. Before touching a patient, before a procedure, after the body fluid risk, exposure risk, after touching a patient, and after touching patients. These are areas where we should be using the hand scrub or the hand wash in the ICUs. We can either use soap and water, or we can use the alcohol-based hand sanitizer. Soap and water is usually initially used for entering the ICU, but we have to thoroughly wash our hands, dry them, and use a single towel and dispose the towel. Afterwards, which we will be using the alcohol-based hand sanitizer. How to hand wash? This is a very important step in the infection control. It should be for 40 to 60 seconds, and all the steps should be performed by everyone. The first step is always wetting the hand with water, applying enough soap. Then you follow the procedures of rubbing the hands palm to palm, over the palms, with fingers interlocked. Then rotational rubbing of the thumbs and the fingers, and rotational rubbing backwards and forwards with clasped fingers. Then rinsing with water and thoroughly drying the hand with a single use towel. Very important. And use the towel to turn off the faucet. Here it's important that we know that we use the elbow taps and not touch the tap after washing. Then they are safe. Now each step is very important here, and none of the steps should be missed, so that we have done a thorough hand washing. Similarly, a hand rub can be used in a similar manner, and that usually takes 30 to 30 seconds for a thorough hand rub, and then the hand should be dry before use. Now coming to personal protection equipment. We know that these days we use this a lot, but it is definitely used in areas, the NICU, where we deal with the babies. First of all is a gloves. Gloves can come in different types: latex, vinyl, and nitrile materials. They are worn during direct contact with body, blood fluids, mucous membranes, non-intact skin, and any other potential infectious material is also used as a part of contact precautions when a person is already infected with pathogens. Discarding the gloves at a point of use and washing the hands immediately after removing the gloves is the must. The next PPE would be gowns. We wear them in the ICUs. 1, 2 as contact precaution. Second is to when we're doing procedures. Fluid resistant gowns are used when splashes or sprays of blood body fluids are expected. These gowns should always be worn in combination with other PPE equipment to make it more effective. Then we have the surgical mask. Different varieties of masks available. We have the surgical mask with the procedure mask. The main important thing is to protect ourselves from the mouth, protect the mouth and the nose and ourselves from splashes or sprays of blood and body fluids or any other respiratory secretions. Surgical masks are cleared by the FDA as having fluid resistant properties. We have different varieties of masks now, which have incorporated face shields also. But preferably, goggles or face shields are to be typically used to protect the eyes from splashes of sprays of blood and body fluids. Now, it's important to note that spectacles and contact lenses are not enough to protect your eyes from body fluids. Now, we have the most important thing is the respiratory protection that now comes in N95 mask. We have the air purifying respiratory masks, which are called the PAPR. So these have to be used along with all the PPEs so that we are protected against the respiratory pathogens. Important thing we always have to remember is infection control is the prevention of needle stick and sharp injuries, which we often ignore. Now, in an ICU, there are different activities which make us vulnerable for needle stick injuries. And remember that don't try to recap a needle and dispose the needles in puncture resistant sharp containers, like this shown in the picture. Do not throw away the needles into trash cans or toilets or bottle cans or recycled bins. Another important thing is cough etiquette. These days, we are learning a lot during the COVID times how to use the tissue, cover ourselves with a mask, and wash our hands frequently. Next important step in infection control is environmental control. Now, for contact isolation, before entering the room, one has to wear gloves, wear a gown, wash your hands, wear a gown, and wear the gloves before entering the room. For airborne precautions, one should wash hands, wear an N95 mask, wear the PPE, and enter the room. And the door to the room must always remain closed. Before leaving the room, remove the respirator and dispose it. When entering an area where there is droplet infection spread, one has to clean hands, wear a mask, and wear goggles, especially when we are doing procedures and also when we enter the areas where COVID-19 or similar respiratory infections are present. Housekeeping is very important, and this is an area where we have to show importance, and that goes a long way in prevention of infection. Usually twice a day, better to mop rather than sweep, use vacuum cleaners, and we use the disinfectants. Now, a word about the linen use. All soiled linen should be discarded in leak-proof bags, or when we're taking it to laundry, it should be put in bags and taken. Then about the feeding utensils we use in our ICUs, they should be cleaned up every feed, and always linen and other utensils should be available. Diaper change should be done with disposable gloves. Waste disposal is another very, very important area which is often ignored and where infection can spread. Now, waste must be placed in color-coded leakage bags, and soiled diapers and medical waste should be collected every 3 to 6 hourly. Now, in this picture, it is very clearly shown how the biomedical waste should be segregated and then disposed of appropriately. If not done, again, there is spread of infection. So every ICU, every hospital trains their nurses and health personnel in biomedical waste management. And please see that you adhere to this proper coding. Again, a word on visitor management. In the ICUs, especially in the neonatal ICUs, preferably mothers and parents allowed, visitors should be treated on an individual basis. They should be wearing PPE. They should be doing hand hygiene. Preferably try to avoid entering as much as possible. In the neonatal care, we have certain techniques which we have to adhere to so that we prevent infections. The clean techniques are usually by using hand rub before a patient examination, before noting vitals, before feeding, and all the instruments should be disinfected. Aseptic techniques, especially by washing hands before doing central lines, and all the equipments again should be disinfected. Sterile techniques are done wherein we use surgical hand scrub, hand wash before especially using the or inserting the central lines. Now, the hospital infection control policies are very important in any hospital so that all these methods and protocols are followed very stringently. Now, there are standard precautions already which I have already shown, and strict protocols should be there in asepsis and sterility. Following protocols of PPE in different areas is also important, as well as following the staffing norms, the employee health, and a good surveillance mechanism is important in any infection control policy. By staffing norms, I mean by the proper ratio of nurses in ICUs requiring level 1, level 2, and level 3 cares. Level 3 cares, we need to have more staffing, and the infrastructure should be appropriate, and there should be enough space between newborns, and there should be effective air ventilation and air changes. Now, regarding the health of the employees, we should have enough PPE available. We should have immunization given to the nurses and the health personnel working in the ICU, and proper infection safety and sharp disposal. Preventing and treating needle stick injuries is also important. Now, coming to surveillance, we should have a robust surveillance in our ICUs. The cultures should be regularly reviewed, and if there is an outbreak, we should be taking measures to contain it, and there should be a good antibiotic policy, antibiotic stewardship program in the ICU, wherein we should have the policy written, and whenever we go to the higher antibiotics, we should be able to de-escalate also when the culture results are available. Remember to stop antibiotics after your culture reports come negative, and remember to reserve the higher antibiotics for sicker babies. A variety of antiseptic, disinfectant, gellants are available, and each unit has their own policy. Use them properly and use them correctly. Conclusion: hand washing and hand rubbing, very important. Minimal handling is the key, and mother is the best nurse of the baby. Of course, breast milk is the first vaccine and the best antidote. And a conscious, determined effort and health education is our moral responsibility. Now, a word about sepsis prevention in the unit ICU. Again, we can use all these measures which I've already told you, and specifically in the ICU, we have to understand that our newborns are vulnerable to infections. They have decreased cellular humoral immunity. Their complement function is decreased, and therefore the incidence is high in our country, and also the mortality is high. So one important aspect when we work in the neonatal ICUs as doctors and nurses is to always remember that our patients are very vulnerable, and we should always be conscious of our actions in an ICU. And we know the risk factors which contribute to sepsis in the newborn. If they are premature babies, low birth weight babies, the rupture of membranes more than 18 hours, if the mother has fever or chorioamnionitis, or if there is a birth asphyxia, all these contribute to sepsis. Such babies, we may need to have antibiotic prophylaxis. It is always good antenatal care will provide maternal immunization against diseases. But in case mothers are born with hepatitis B, we should be able to provide with the proper immunoglobulin. Now, the general measures which we use for prevention of sepsis in the newborn is that we provide a proper resuscitation area in the labor room, which has an access to hand hygiene and hand wash. Then we use the PPE equipment and prevent entry of microbes by doing the 6 cleans, that is, clean areas, clean hands, etc. And we welcome the baby with sterile hands, with sterile equipments, and we do selective admissions to the ICU to avoid overcrowding. Here is an example of keeping everything ready in the resuscitation area. so that, and a clean environment is necessary for a baby to be conceived. Here is the equipment kept ready, and follow all the standard precautions which I have already mentioned. And how to prevent microbes entering the ICU. Restrict the entry of family members, isolate the infected infants so that different staff can take care of infected infants. Keeping away doctors and nurses who are already infected, treating them. And hand washing, hand rubbing should be our obsession always. Keeping our hands clean to take care of the tiny newborns. Wearing of PPE. Remember, your air conditioners also can cause infection. There should be bacterial filters should be washed and cleaned, and frequent air changes should be there. Then, now, how to prevent proliferation of microbes? That is by cleaning, disinfection, and sterilization. Sterilization will be destroying the bacteria and the spores, and we have different methods now to do all these three. Good housekeeping is very, very important, as I've already mentioned. We could have a daily and weekly routine in the ICU and keep all our equipment, the ventilators, the warmers, the suction bottles, everything should be cleaned regularly. And remember the walls, the floor, and the dustbins also. We have a variety of disinfectants, and each unit has a policy. Now, the ventilator and CPAP circuits should be changed weekly. And remember to autoclave your procedure sets. And the feeding utensils and everything which has been used should be cleaned. Waste disposal again, and we have already spoken about, is a very important method of infection control. Now, we could have a chart like this to remind us to clean these areas, because often we forget the telephone or the table to be clean. How do you protect newborns from infections? Now, generally, we have certain measures specifically for the newborns which help them to prevent infections and protect them. First of all is a breast milk. Please start breast milk as early as possible, even in the sick babies. Tell the mother the importance of colostrum. If you're not able to feed babies, not able to provide, give minimal nutrition in terms of colostrum and breast milk with minimum quantities. Remember, breast milk contains a lot of antibiotics and is the first vaccine to the baby. Then care by the mother herself is very important and prevents infection. Then kangaroo mother care, which is actually placing babies on the mother's chest, is found to be effective in preventing infection. Then early discharge of babies, cord care and skin care daily is very important in preventing pathogens. Then of course, a good antibiotic stewardship, by which I mean a proper antibiotic and removal of antibiotics when the culture becomes negative is very, very important in preventing infections. Then when we start our IV and prepare our TPN and our drugs, and we use central line precaution, then minimum handling of babies. Whenever we do procedures, intubation or LPs or suctioning, remember to wear the PPE and use proper precautions. Use disposables as much as possible. All these things protect our newborns from infections. Preventing spread between babies by proper staffing pattern, hand washing, and cleaning of all equipment and avoiding overcrowding. Environmental surveillance in the ICU, recording the positive cultures, a proper antibiotic policy, and contingency plans for epidemics is very important. And the hospital administration has provided us with committees and infection control measures for all these things. Educating health personnel frequently and always remembering them and reminding them of hand washing. In conclusion, prevention is always cost effective. Fastidious housekeeping pays. Remember, newborns are fragile and handle them with care. Thank you. Thank you very much.
Good afternoon, Kamala.
Madam, I will share it a video.
Yes, please show them a video clip so that they'll remember. about infection control.
Okay.
We all know about the growing threat of antimicrobial resistance and have seen the headlines about superbugs and nightmare bacteria. Unfortunately, this threat is very real. Now more than ever, it's critical that we work together to contain these drug-resistant pathogens and the infections they cause. Keeping our hands clean is one of the most important ways to prevent the spread of infections. Every time we enter the patient zone, we can get dangerous germs on our hands and spread them to ourselves or to other patients. Sometimes we don't clean our hands as often as we should, not because we mean to do harm, but because it's a daunting task. Some of us might have to do it 100 times a day. It takes dedication, mindfulness, and time. Our patients' lives depend on it. Let's applaud the efforts and improvements we've already made. Increases in hand hygiene adherence have led to decreases in healthcare-associated infections. At the same time, we know there is still room for improvement. We can all do better. Our clean hands count, now more than ever.
Thank you. There are questions I can take.
Then there are no questions in the chat box.
So, thank you, ma'am.
Ma'am, please brief about
No,
it.
one question is there, no?
Yes.
Nice NICU arrangement so as to reduce infection.
CDC helps to stop the spread of diseases and to keep people from getting sick. We're kind of like detectives, but instead of stopping bad guys, we help to stop germs and diseases. Our job is to use clues to figure out how people get sick. Then we use that information to try to prevent people from getting sick. And hand washing is one of the ways you can do that.
And I'm Sarah. I also work at the CDC events.
We're here today to talk to you about global.
Madam, can you answer that question?
Yes, NICU arrangements so as to reduce infection, arranging area for each procedure, including isolation. Yes, I think it's very important as we plan the ICU itself, we should have a pattern followed. I think there are a lot of, even in the internet, it's available. See, all the space between a baby, okay, your hand washing area, your feed preparation area where you store drugs, your crash cot, everything has to be placed. Okay, so that most important would be spacing between the babies, and then your where you keep all instruments and all your things. So each baby should be separate. Then you have the hand rub in each cot. So all these things matter first. Then, of course, reducing infection would be to have a hand washing area separately, and then feed preparation area. Now, for procedures, arranging a procedure area may not be easy for every ICU, but of course, if we have, then isolation definitely, I would like to have an isolated area, a room separately itself for babies who have infection. So those are small things. And anything else you'd like to know? You can type. I shall answer by typing.
Ma'am, we have one more question. What are the precautions to take for the prevention of infection in babies with open sternum?
Open sternum.
Probably post cardiothoracic surgery with open sternum.
Okay. Specific precautions, of course, we have the general precautions, and specifically it's an open wound. So, the baby itself will be prone to infection. So I think there are some materials which I'm not sure the surgeon may be in a better position to say that, isn't it, Kamala? I don't exactly think we have general precautions only.
Right, ma'am.
Anybody can add if you want. PMC, sir?
And there is one more question.
Yeah.
How much distance between two warmers in the NICU?
Ideally, it's around 3 to 4 feet, but I'm not sure in every ICU they follow because of constraint, but usually around 3 to 4 feet.
Okay, ma'am.
Thank you, ma'am, for that very important and very interesting discussion. So we'll move on to the fifth discussion, that is how to identify a sick neonate by Dr. Hasina, madam. Dr. Hasina KR is the senior consultant neonatologist in NIMS Hospital and is known for her dedicated and passionate state-of-art newborn care in her hospital and for her efforts in creating community awareness in essential newborn care. I welcome you, madam, to train us on how to identify a sick neonate at the earliest.
Yeah, answer it.
Good afternoon and a very warm welcome to all of you. I'm sure that all of you might have joined the CNE with the idea to improve your knowledge in newborn care. I'm Dr. Hasina, Chief Consultant Neonatologist at NIMS Medicity. And our topic today is how to identify a sick newborn. So every year, 30 million babies are born either too soon or too small or become sick and are at the greatest risk of death or disability. And if we gain enough knowledge and the skill to take care of the newborns, we can contribute a lot to changing this problem. Well, let us ask some basic questions. Why should we identify a sick newborn? They have very non-specific symptoms. They are unable to communicate, and we might very well miss the symptoms. Even if we pick up the symptoms, it may not help to reach a definitive diagnosis. And the disease process progress very fast because of their physiology, and they may die within minutes in front of our very eyes. And this results in delay in seeking care. Because the symptoms are very non-specific, it results in delay in seeking care and adds on to the morbidity and mortality. Now, when should we identify? We should identify a sick baby as early as possible so that we can offer early treatment and arrange timely referral. They have to be identified at the right time, and we should allow them to go to the right place in the right possible way and get the right treatment. This is the right of every newborn that we care. And where and when should we identify? It should be done immediately after birth, as soon as we start resuscitation. While in the postnatal ward, while in the NICU, we should keep on picking up symptoms of the baby worsens. At the time of discharge, we should examine the baby. While at home, baby should be constantly monitored. And whenever the caregiver is concerned, we have to examine the baby and identify whether baby is sick or not. Now, who is responsible for identifying sick babies? Any caregiver, be it mother, father, grandparents, neighbors, or any friends in the neighborhood, whoever is seeing the baby need to be able to identify their problem so that they can take the baby to a healthcare facility. Besides, midwives, JPHM DIs who usually do home visits also need to be aware of the signs through which they can pick up sick babies.
Then the healthcare providers, like doctors and staff nurses who are working in hospital setting, also need to know how to identify a sick baby. Now, to identify a sick baby, we definitely need to know what is normal. So what is normal for a newborn? Normal weight should be between 2.5 to 4 kg. They should have good cry, good activity, normal tone, and they should be moving all 4 limbs normally and feeding well. They have a normal breathing pattern, which is like 40 to 60 per minute. The respiratory rate should be between 40 to 60 per minute. There is no nasal flaring, no grunting, no retractions, and baby is breathing very comfortable. Normal heart rate is between 120 to 160 per minute. And baby should be warm and pink, and they should be able to sleep normally after an adequate feed. They should have passed meconium within 24 hours of birth and urine within 48 hours of birth. And obviously, there should be no external anomalies. So any baby whom we come across, we should definitely measure the weight, length, and head circumference so that we know how the baby is growing. We should know the gestational age to identify whether it is a preterm or a term baby, because preterm babies usually require more intensive care than a term baby. And a fast head to foot examination has to be made, arranging, beginning from the scalp to the feet. We should look at the genitals, we should look at the abdomen, we should look at the external extremities, so as to identify whether any anomalies are there or whether anything away from the normal is there. And you should always look at how the baby is lying, the posture of the baby, the tone of the baby. And there are neonatal reflexes as well, which we should be knowing, but we cannot examine all the neonatal reflexes in a baby who has been brought with a sickness. But 2 important neonatal reflexes that we all can see are sucking reflex and rooting reflex. If a baby is sucking well, we know that the sucking reflex is intact. And if you touch the cheek of the baby, baby usually turns the cheek to the same side. That is, if the baby's cheek is touched with the breast of the mother, the baby usually turns the face to that side for sucking from breast. So that is known as rooting reflex. If both these reflexes are intact, that is, if the sucking as well as the rooting is intact, it conveys the message that baby is able to suck well at breast. Whatever you're finding us, always inform your doctor. Even if you're very confident about the finding, it's always better to connect to a senior. Now let us see what the danger signs are. First of all, what is danger sign? These are signs, if we neglect, can progress to a very severe illness and can result in morbidity and mortality. So it is mandatory that we pick up danger signs as early as possible. These are poor feeding, lethargy, and poor activity. Mother herself will know that babies who were feeding well is now not feeding appropriately. So they complain about poor feeding, and through our examination also we can find that the babies have poor feeding, lethargy, or poor activity. And bluish discoloration of the skin is known as cyanosis. And there will be respiratory distress, which can be sign of any heart disease or pneumonia or RDS in a preterm baby. Abdominal distension has to be evaluated. Sometimes we can see the dilated bowel loops moving across that, which is known as visible peristalsis. Vomiting is actually a normal sign in almost all newborns, but many babies will have more frequent vomiting. Sometimes it will be copious amount of projectile vomiting. They may not be gaining weight. Sometimes it could be bilious vomiting. These need evaluation. Jaundice is usually physiological in majority of babies, but sometimes it could be pathological. It could begin early and last long, and they may have very high values. If high values are not addressed immediately, it can accumulate in the brain and then cause neurological disability. Diarrhea, Hypothermia, fever, seizures, bleeding, excessive crying, and inadequate weight gain are also danger signs. Let us see how you assess the yellowish staining of the soles. We can just press the soles for a while and release. Usually it will be white in color, whereas if yellow stain is present, it is a danger sign. Yellowish staining of the sole is a danger sign. It means that the bilirubin level could be as high as 20 or even above. Now from this picture, which one of the baby is looking really sick? Let us see the first picture of the left side corner. This baby is looking alert and pink, and baby is trying to suck his or her fingers. So this baby looks fine and term. Look at the last picture, right hand side bottom corner. That baby looks small, reddish and preterm, and the baby is lying lethargic with lots of wires around the body. So that baby is definitely sick. And look at the baby in the right upper quadrant. This baby is small. This baby has a pink skin, but the skin is not as mature as the left side term baby. The hair is also looking immature and curly. Eyes are closed and baby is sleepy, and oxygen is being given to the baby. So this baby is a preterm baby, even though the baby is not looking very sick, but sleepy. Baby has the potential to become more sick. So we need to identify at-risk babies as well who can go in for sickness. Now this is the most important part of identifying a sick baby. This mnemonic is STOPS. The expansion of STOPS is sensorium, temperature, oxygenation, perfusion, and sugars. So if you assess the STOPS of a baby, you will be able to identify whether the baby is well or unwell. So STOPS is an important mnemonic that all of us should remember all through our life if we are examining a sick baby or a sick patient. What are the components that we see? That is sensorium, temperature, oxygenation, perfusion, and sugar. You have to remember that we need to assess the baby once and then reassessment. That is always has to be done, even if we are not able to pick up sickness for the baby. If the baby is looking well, after a while, the picture can go wrong. So we need to reassess the baby. Let us see one by one. A sensorium, as we all know, it indicates how the baby is responding to the surrounding. Is the baby remaining alert? Is the baby able to arouse spontaneously? Whether they have active movement and cries normally. They are defined as babies who have normal sensorium, and the score of 0 can be given. If the baby has irritability, poor response to touch, weak cry and lethargy, then score of 1 is given. Now, if the baby is very floppy, unresponsive, apneic episodes, and the baby is having seizures at the time of admission, that's a severely sick baby, as any one of you can identify. For babies such as that, we give a score of 2. And there is another scale, that is ABPU scale, which is like baby is alert and baby responds to verbal sound fully, or baby responds only to pain or unresponsive pain. This also can be used in the assessment of sensorium. So it is ABPU, which is alert, verbal sound, responding to verbal sound, responding just to pain, and unresponsive. This picture shows a baby who is having very lethargic face. From the face itself, we can identify whether the baby is having lethargic eyes. The eye opening will be as if baby is very much tired. So after S, it is T. temperature in the Neocon. So normal temperature is between 36.5 to 37.5. When the baby's temperature is between 36 to 36.5, it is known as cold stress. How can you assess whether the baby is in cold stress? You use the dorsum of your hand. The dorsum of the hand is used to assess temperature at the sole or the extremities. And then you assess temperature of the abdomen. If the temperature of the abdomen and the peripheries are same, then baby's temperature is normal. But if the peripheries are colder than abdomen, then you can very well say that the baby is in cold stress and this baby has to be wrapped up properly, or else skin to skin contact has to be given, and we need to reassess the baby after 1 hour. If the temperature has normalized, baby is normal, it was just an environmental problem or you did not cover the baby properly. But if after 1 hour also baby is in cold stress, it could indicate that the baby is having sepsis. Now, if the temperature is between 35 to 36, it is mild hypothermia. If it is between 32 to 35, it is moderate hypothermia. And if it is below 32, it is severe hypothermia. And any baby in severe hypothermia needs urgent care and has to be placed under warmer to give slow rewarming. Apart from the tactile method, we can use a thermometer also to assess the temperature. The thermometer has to be placed in the axilla. The bulb has to be in the axilla. Before that, you have to wipe the thermometer and always keep the thermometer in a dry method. And it has to be placed parallel to the body of the baby. It has to be placed in the axilla for 3 minutes. A thermistor probe of the warmer also will help us to measure baby's temperature. If the baby is under a warmer, heater output of the servo-controlled radiant warmer has to be recorded, because if heater output is more than 20 multiple times, it means that either the warmer is not working properly, it is providing more heat, or the baby is not getting warmed up properly, either because you have placed baby in an abnormal way, baby is not placed just below the radiant warmer. So we need to place the baby in a proper way. Sometimes it could also mean that the thermistor probe is misplaced from the baby's body. Now, after temperature, after completing sensorium and temperature, we are coming to oxygenation. In oxygenation, we look for the presence of respiratory distress and the requirement of oxygen for maintaining saturation. If baby has no respiratory distress, not requiring oxygen to maintain SpO2, the score is 0. If baby has a respiratory distress with rate between 60 to 80 and mild chest retractions, mild grunt, and requiring FiO2 less than 60, the score 1. If the respiratory rate is more than 80 with severe grunt, marked chest retractions, and FiO2 requirement more than 60 or CPAP or ventilator support is required, then score 2 is given. Now we all know that respiratory rate has to be checked for a complete 1 minute. Otherwise, we will not get proper respiratory rate. The normal rate is between 40 to 60. We should look for apnea and the pattern of breathing. And many babies have periodic breathing which occurs during sleep. It could be fast in between, it could be slow in between. That is why we need to check respiratory rate for complete 1 minute. Look for signs of respiratory distress like audible grunt, chest retraction, and nasal flaring, and movement of the body as well, movement of the head and neck region as well. Now look at this picture. The face itself tells that the baby is sick and tired. And just look below the nipple area where you see a retraction of the subcostal retraction of the area. That is the location where you look for retractions. Now this is the picture showing central cyanosis. This baby is also having dysmorphism. It's a Down syndrome baby with central cyanosis. So it might indicate that the baby is having some congenital cyanotic heart disease. It can also occur when the baby is having severe respiratory distress or pulmonary hypertension. So what is the machine that is used to measure saturation? This pulse oximeter. It is usually connected to the right upper limb to get proper saturation. And after delivery, if you connect pulse oximeter to the right upper limb, by 1 minute, the saturation will be around 65. It takes about 10 minutes to reach saturation of 85 to 95. So up to 10 minutes, we need not provide oxygen even if the saturation is around 80. And we need to check pre as well as post ductal difference for pulmonary hypertension. As we have already seen, respiratory and cardiac causes can cause low saturation. And if cold extremities and shock is present for the baby, then we may not pick up a right saturation. Now, after completing sensorium, temperature, and oxygenation, we have reached perfusion. Perfusion means an indicator of circulation. Adequate circulation of blood is required to transport nutrition as well as oxygen to the baby's body parts. So it is indicated by heart rate, CRP, and BP. Heart rates of the baby has to be counted for full 1 minute, and it is normally between 120 to 160. Capillary refill time has to be checked, and a score of 0 is given when the heart rate is between 100 to 160 and CRP is less than 3 seconds. Score of 1 when the baby's heart rate is more than 160 and CRP is more than 3 seconds. Now, if the baby has cold and clammy extremities and CRP is more than 5 or presence of bradycardia, it means the score is 2. Now, how do you assess capillary refill time? We apply pressure over the sternum for 5 seconds. And then once you release, you notice, as you see in this right picture, you notice a blanched area. And you have to count 1001, 1002, 1003 briskly. And within this time, the blanched area should become pink in color. That is how you assess capillary refill time. We can either do it over the sternum or the forehead. Extremities is not selected in a newborn baby because it could be cold, it will not give the correct response. Now, blood pressure is an indicator of proper circulation or perfusion. It can be measured by non-invasive oscillometric method or invasive intra-arterial most accurate. We have to choose appropriate extremity and appropriate cuff size. Only then we will be able to get proper blood pressure. But this can be done only in a hospital setting. We need to always take care of the intravenous lines or SpO2 monitoring. Four-limb BP is measured in certain conditions like cardiac disease. Apart from this, what are the clinical measures that will help you to identify whether the baby is in shock? Poor activity, irritability, tachypnea, which is increased respiratory rate, skin mottling, cold peripheries, prolonged capillary refill time, and reduced urine output, which is less than 1 ml per kg per hour. By the way, normal urine output is between 1 to 3 ml per kg per hour. And if we have the facility to check venous blood gas, it will show metabolic acidosis if the baby is in shock. Now we have completed perfusion. The next one that is remaining in the mnemonic stops is sugars. Capillary blood glucose is checked using the glucometer by the heel prick method. The score 1 is given when the blood glucose is between 45 to 180. Ideally, we say baby's blood sugar should be between 45 to 125. Any value more than 125 is hyperglycemia, but more than 180, we need to take some action. And score 1 is given when sugars is less than 45 or more than 180. And this setting we can manage the baby with oral feeds. And with oral feeds, the sugar might improve. But whereas if the sugar is less than 45 and the baby is not improving with oral feeds, we will have to go for IV cannula and give bolus of sugar, bolus of 10% dextrose, that is 2 ml per kg per hour, and start IV fluid at the rate of 4 to 6 milligram per kg per minute initially. Later on, go on to higher requirement, higher dose if the baby is requiring more. So finally, what are the parts of stops? The sensorium, temperature, oxygenation, perfusion, and sugars. These has to be assessed in every baby you see in order to identify whether the baby is sick or not sick. We should also know about the golden hour concept, which is like when you see the baby, you start assessing the baby and reach a consensus, and we need to know what has to be done for the baby and have a coordinated action plan. Do it as fast as you can, so that we can provide accurate management, adequate management to the baby, and thus help the baby to improve within an hour of being seen. So here we have to assess the airway, breathing, and circulation of the baby, as well as the temperature, because all these 4 are important for baby survival. We need to assess activity, facial expression, tone and posture, abdomen, and skin has to be assessed for texture and color. Color, we know it could be cyanosed, it could be jaundice, sometimes it could be pale in anemia. Look for pustules or skin lesions. All vitals need to be checked, including sugars. And we need to ask questions after seeing the baby. Is feeding possible for this baby? If possible, can the baby directly breastfeed, or we need to give Palada feed or rice tube feed? Does the baby require IV cannulation? Does the baby need IV antibiotics or inotropes or IV fluid or any kind of boluses? Is respiratory support needed for the baby, whether it can be just oxygen therapy or CPAP or invasive ventilation? Is the baby requiring admission or just observation, or we need to refer the baby to a higher center? Finally, keep on assessing the baby and see whether the baby is improving with the measures that we have taken. Let us also say a word about the integrated management of neonatal and childhood illness approach, which was introduced way back in 2004, where they say we have to look at the baby, ask questions to the bystanders, to the parents, and listen very well, and feel and touch the baby in order to diagnose and assess the baby. So it is look, ask, listen, feel, and touch. So triaging is the concept which has to be used when we are trying to identify a sick baby. First, identify whether the baby is well or unwell. If unwell, is it a life-threatening situation? Should we immediately start bag and mask ventilation and help the baby breathe? Should the baby be started on measures like IV fluid bolus or inotropes so as to maintain the circulation? Is it an emergent situation? Is the baby in hypothermia, severe hypothermia, that requires the baby to be kept under warmer and adequate measures initiated? Is it an urgent situation, whether the sugar is low and baby has to be given immediately, IV cannula has to be put and started, bolus, and 10% dextrose has to be given? Or is it a normal baby with some minimal illness which require just OPD management? And we need to follow up and reassess the baby. Reassessment is the crux in identifying a sick newborn. Now, documentation is very, very important when we are seeing a baby. If it is not documented, it means it is not done. You assess, always remember to inform whatever your findings are, keep reassessing the baby, have a nursing diagnosis, and bring up an idea of plan of action, what has been done, what is to be done, and what are the improvements shown. always keep trying to improve the skills in communication. It's not only necessary that we identify the illness of the baby, but we need to have a skill in communicating with the parents, help to reassure the parents, explain what you have seen with compassion and care, and counsel them regarding further signs that you are anticipating. We should also be able to communicate with our colleagues and seniors in case of doubt, and always think aloud. If you see a baby and you have a doubt, it's better to think aloud or talk about that to your colleague, and never neglect an information that you gain by examining the baby or talking with your parent. And while caring the baby, provide general care, do no harm, be less invasive, avoid frequent touching, try to club all the activities together, and initiate early feeding. Try to keep the baby in midline position, provide adequate bedding and nesting. From the picture, you can see that you can go in for costly affairs as well as you can use whatever material is available with us, like at home. Control light and noise. Always try to reduce pain, because babies keep crying and we neglect that babies can experience pain, and that can affect them neurologically a lot. Try to provide family-centered care. And while caring the baby, it is very important that we anticipate problems. And if we anticipate problems, we can plan properly, we can evaluate and act properly, and keep re-evaluating. So it's better that we know any maternal risk and fetal risk upfront itself, so that we can anticipate a problem and take adequate measures. And always know that caring of the baby is a teamwork. Identifying the sick baby is also a teamwork. And the team leader can decide who is doing what. Team leader need not be the doctor. It can be an in-charge nurse or a staff nurse. They can decide who is going to attend the delivery, who is going to give care to the baby, who is going to attend the emergency needs, the pharmacy checks, the equipment needs, and documentation and communication. In a big setup where there are multiple people, you can think that different people can be assigned different jobs. But when there is only one or two people, then we have to prioritize our job. The emergency care has to be given at whatever point it is required, and documentation and communication can come last, but it has to be done. Now, WHO and every newborn action plan says that deaths in the neonatal period is nearly half of all under 5 deaths, and 30 million newborns require inpatient care every year, whereas approximately half do not have access to neonatal care service. And those who have access often receive care of suboptimal quality. So if we all can try and attain more knowledge and more skills in taking care of these newborns, and disseminate the knowledge that you attain to your neighborhood, to your friends, to your families, then we may be able to attain the Sustainable Development Goals by 2030, which is to reduce the national neonatal mortality rate to less than 12 per 1,000 live births. We need to accelerate progress and invest in maternal and newborn health now. So with good antenatal care, good resuscitation facility, early and exclusive breastfeeding, compassionate nursing, and early identification and prompt management, we will be able to save a lot more lives, especially in these trying COVID times where many of us are working hard to help those around us. We need to work more hard in order to keep our neonatal mortality rate at least static without allowing it to increase. And I would always say that NICU nurses are angels. Thank you, and stay safe, all of you.
Thank you, madam. We have one question in the chat box. Why we should keep the baby in the midline position?
Hello, can I answer? Am I audible?
Yes, ma'am.
Okay, keeping in midline position is actually useful for their neurological. They have to have. It's not only that the survival of the baby is important while we take care of the baby. Their quality of survival, the neurology has to be intact. So midline position always allows them to have a good survival, and we can have like whenever the baby is in a lying position, sometimes we see in the NICU itself, we see that the baby's head is in one position, the limbs will be in another position. So we have to arrange a proper bedding so that they will be comfortable as possible. This helps in intact neurological survival.
Thank you, ma'am. Thank you so much for those words of wisdom. Next, we'll have a discussion about feeding of low birth weight babies by Dr. Jyoti, madam. Dr. Jyoti Prabhagar is the senior consultant neonatologist in KIMS Hospital. She is well known for her expertise, research activities, and publications in the field of preterm care and management. I invite you, ma'am, to discuss regarding the feeding of low birth weight babies.
Hope all of you are doing fine. I'm Dr. Jyoti Prabhagar, consultant neonatologist at KIMS Hospital, Trivandrum. Today, I'm going to talk on low birth weight feeding. Remembering those dedicated healthcare workers who lost their lives in the battlefield against the pandemic, and all our co-workers who are sincerely and tirelessly working to save and protect human lives. In today's discussion, let me start with 3 case scenarios. Scenario 1, this baby was born at term 38 weeks, 2.2 kg at birth, born by normal delivery. Baby was discharged after 72 hours and was referred to us on day 5 with complaints of poor activity and poor feeding. Weight at admission was 1.5 kg. There was significant weight loss, around 30% weight loss. Sugar at admission was 15 mg percentage. This baby got admitted to NICU, received full supportive management, and on follow-up at 2 years, this child is a case of development delay and she is blind. Second case, this is a late preterm baby, born at 36 weeks with a weight of 3.5 kg, infant of diabetic mother, born by normal delivery. This baby got discharged after 48 hours and was referred to us on day 6 with recurrent seizures and jaundice. And at admission, weight was 2.6 kg. There was significant weight loss of around 30%. RBS was stable. Bilirubin was 25 mg percentage. Sodium 185 milliequivalents per liter. There was dehydration. And at 3 years, this child is cerebral palsy with recurrent seizures and is hearing impaired. The third scenario, this baby was born at extreme preterm, 28 weeks, 1 kg at birth. Baby had a stomach cause in NICU, long NICU stay, and as you see in the chart, baby at around 40 days has significantly lost weight. Baby's weight was 720 grams instead of reaching a weight of 1.4 to 1.5. The baby was inside mother's uterus. Where these situations avoidable, every case is the answer. Nutritional guidelines on low birth weight has been published. in India by Government of India. And in India, about 7.5 million infants are born low birth weight, in the range of less than 2.5 kg every year. The nutritional management of low birth weight babies is important as it influences not only their immediate survival but also subsequent growth and long-term neurodevelopment. There are two different categories of low birth weight babies: term intrauterine growth retarded babies, and the second category is preterm babies with a birth weight of less than 2.5 kg. Mostly these babies are of appropriate for gestation age as they are born preterm, weight is less than 2.5. First, let us discuss about term IUGR babies. That was our first case. The baby was born at 38 weeks with a weight of 2.2 kg. I just want to mention about another small for gestational age babies. These babies are born small because of the familiar nature. The parents are small. Example, Nigerian families, Chinese, or they are small. So this is not because of the inappropriate uterine environment. These babies on follow-up will grow well, track their parental centers, and neurodevelopment, growth and development will be okay. Whereas in intrauterine growth retardation, these fetuses are inside the uterus, they are inside the uterine environment is not appropriate. There is high risk of immuno deterioration, high risk of stillbirths, there is a poor postnatal outcomes. These babies require maybe an ICU stay, special care, and obviously they need long-term follow-up. Mostly this is due to poor fetal adaptation due to hypoxia, placental insufficiency, as it happens in pregnancy, hypertension, chronic maternal diseases, etc. Rarely this can be due to chromosomal anomalies or torch infections. Anyway, whatever be the reason, these growth retarded babies, they require close monitoring with ultrasound, and the baby doctor studies, serial growth monitoring extra will be done, and a planned delivery will be run by the gynecologist. So, what are the problems after delivery? They are at high risk of asphyxia, emasculation syndrome, BPHN. The risk of hypothermia is more in these small babies. Risk of hypoglycemia is more. Polycythemia, thrombocytopenia, hypocalcemia, and obviously mostly they will get breastfeeding problems. They are small, they will not be able to suck effectively, so they need support. Mothers also need extra support. There can be a risk of feed intolerance also. And these mothers need more support and motivation. Maybe you can start with in contact in the early hours, lactational support in the early sensitive hours, especially immediately after delivery. In the first 1 or 2 hours, babies will be more alert and active. And if you are able to start lactation by this period, it will be more successful. And always we will have to monitor feeding in these. Even if the mothers say that they are confident and our baby is sucking well, you have to monitor the baby. Effective sucking, baby is effectively sucking, and the baby is sucking long enough to get enough milk. And these mothers need breastfeeding support because of baby issues as well as maternal issues. There can be black nipples, nipple sore, breast engorgement, etc. And these mothers need more emotional support. Sugar monitoring has to be continued in these small babies for minimum 48 to 72 hours. And even though we want the direct breastfeeding and full breastfeeds, if there is hypoglycemia or weight loss, formula feeds may also be needed. At this point, I want to emphasize the discharge should be a planned discharge. Baby should be discharged only when the mother is confident with feeding, not more than expected weight loss. Weight loss up to 10% can be accepted with the initial 3 days. If the weight loss is more, then maybe we will have to hold the baby instead of one mother in the hospital and check whether the sugars are more than 60. Baby sugars are more than 60 beyond 48 hours. Baby passes once at least 1 or 2 times per day, stools 2 to 3 times per day, and the stool has become transitional and not that meconium has to be, the color has to change from greenish or yellowish. Bilirubin should be okay. and baby is able to maintain temperature by appropriate clothing, and all of the blood routines are done, vaccination is done, and the most important is mother should get a pre-discharge counseling. She should be told about the danger signs and when she should report to the hospital. And mostly all these babies require a follow-up within the first week or early as per babies. So that was baby term IUG activity. Next we move on to preterm babies. Preterm babies, the decision on feeding is mainly determined by the gestation. We all know gestational maturity is very, very important for feeding coordination. If gestation cannot be determined, birth weight can be used and baby can be monitored during feeding. So this is the general guideline given by Government of India. That is, if the baby is more than 34 weeks, you can start breastfeeding, but we have to observe if positioning and attachment are good and the baby is able to suck effectively and long enough, that is about 10 to 15 minutes. If baby is effectively sucking and the baby is able to get enough milk, you can continue breastfeeding. If there is any difficulty in feeding, you have to give lactation assistance, may support for proper latching and positioning, and if any issues are there, we may have to start the baby on spoon feeds or parallel feeds. If the baby is between 32 to 34 weeks, we know the baby swallow breath coordination happens more than 34 weeks. So if the baby is less than 34 weeks, these babies need close monitoring. And with these babies, 32 to 34 weeks, babies can be started on parallel feeds. But we have to observe whether the baby is accepting well without any coughing, choking, or spilling, and is able to accept adequate amount. If it is okay, you can continue with parallel feeding and gradually transition to direct breastfeeding. If the baby is born less than 32 weeks, between 28 to 31 weeks, these babies definitely will require an ICU admission. Orogastric feed has to be started, and observe for any vomiting or abdominal distensions or distension of liquid aspirates. If it is known that gastric feeding can be continued, or maybe some babies may require IV fluids if they are unable to accept full volume feeds by kg or mg. And in babies less than 28 weeks, these babies require extra nutritional supplement. Coming to our second scenario, that is of a late preterm baby. This late preterm group, this is between 34 weeks and 37 weeks. So this baby, maybe beyond 37 weeks, we can, even though we consider them as term, now the classification is full term means beyond 39 weeks. So 34 to 37 weeks babies, these are a special group. Why? Because if the baby is less than 34 weeks, they will get admitted in an ICU. If the baby is a term baby, again the issues will be less. But if a baby born between 34 to 37 weeks, mostly they will be having good weight also. So everybody will consider, even the caretakers and the health staff will consider them as normal because of the low weight, and they will not get proper attention. That is the main concern and main worry. So these late preterm, they are given the name late preterm just to emphasize the risk of immaturity related complications. They are at risk of respiratory distress, infections, apnea, risk of life-threatening illness, hypothermia, hypoglycemia, poor feeding, weight loss, jaundice, etc. Their discharge can be delayed and the risk of readmission is also more in this group of babies. But there can be feeding concerns. Remember, these babies are born between 34 to 37 weeks. They are not mature. So the risk of poorer rates of breastfeeding initiation and duration compared to term infants, and they need to be discharged only after lactation is established. Here again, the discharge should be planned. Initially 48 hours, you have to monitor sugars, bilirubin and other routine should be done, and the baby should not have lost more weight. Baby should have passed adequate urine and stools. That guideline is the baby born at 34 weeks, 2 weeks minimum hospital stay should be there. And if the baby is born at 35 weeks, at least for 1 week, baby has to be cared for in the hospital. And a baby who is born at 36 weeks, at least you have to keep the baby inside the hospital for 4 days. This is to see that baby is not having any health issues, baby's feeding is okay, lactation is established, there is no other, bilirubin is okay, weight loss is acceptable, and mother is confident with feeding. And these babies have increased risk of infections, and all these babies need follow-up, regular follow-up, and one follow-up within the first week of discharge. They require, because they are born early, they require supplements. Weight preterm babies should receive 1 to 2 milligram per kg of iron starting from 6 weeks till 6 months. And vitamin D should be supplemented at a dose of 400 international units till 1 year. Now coming to we were discussing about late preterm. They are born between 34 to 37 weeks. Now coming to moderate preterm, they are born between 32 to 34 weeks, roughly 1,500 to 2,000 grams. Invariably, these babies require NICU admission, so they will be separated from the mother. Encourage breast milk expression right from the beginning. Try feeding by pallidie. In this session, I will not be discussing about how to give pallidie feeds, how to give orogastric feeds, cup feeds, and all. I know that you all will be doing much better, and you will be experienced in giving orogastric and pallidie feeds much better than me. So always ensure safety, because we know that their sex follow breath coordination cannot be organized. So we have to be extremely careful while offering pallidie feeds and ensure that baby is able to suck and swallow without coughing and or choking with good speed and proactive nutritional support is needed for these babies. Because of the immaturity, sucking may not be okay, and this uncoordinated suck follow breath organization, and there can be increased risk of choking. And there can be challenges in latching and supply, and these babies need, once they are getting transition to feeds to direct breastfeed, these babies require monitoring and encourage breast milk expression, ensuring stability. This is extremely important because these babies are admitted in an ICU, and encourage mother to come to an ICU. If it is a vaginal delivery, she can come within a few hours. So mother baby separation can be decreased. And these babies require extra vigilance, ensure hemodynamic stability, give lactation support. This is extremely important. ANC can be started. In these babies between 32 to 34 weeks, we know that they get transition to direct breastfeeds early. So maybe pacifiers are not given for these babies. As far as they have an empty effect, baby may not be very keen to suck on the breast. And formula feeds are needed. Sugar monitoring is done, and formula feeds are given if needed. How much feed to start in these babies between 32 to 34 weeks? 60 ml per kg can be started on day 1, and the daily increments of 50 ml per kg. And a few words about formula feed preparation. This is extremely important, and hygiene should be optimum. Feed preparation should happen on a clean surface. Bottles should be properly cleaned using precious soap solution, and the pallidie or smooth and bodily pallidie sterilization and food-based sterilization. Sterilization is not available. It should be boiled in water for 10 to 15 minutes. And water for preparation should be well boiled and lukewarm. If water is boiling water, temperature is more, this can destroy the probiotics and other vitamins components in the powder. And if the water is so very cold, it can increase chances of infection. So ideally, the temperature should be room temperature, around lukewarm temperature, lukewarm water. And it has to be prepared fresh, and it has to be prepared in the bottle. Water has to be heated, and then powder has to be added and changed. And never use these cups and all. But we have seen many times parents mixing feeds in this plastic cups and open pans and all. This has to be discouraged, and the freshly prepared feed should be given to the baby. Discard the remaining feeds, and always keep the utensils clean and sterilized. These babies, the preterm babies with a weight of less than 1,800 grams require supplement. These babies, when they are towards the last trimester, maximum transfer of nutrients happens from the placenta. As these babies are born early, they require nutritional supplementation. Nutrition is important for their growth and as well as mineral supply, calcium, phosphorus, vitamin D, iron, etc. are required for their health. So calcium and phosphorus should be supplied. Government of India guidelines. Calcium is supplied at a rate of 120 to 140 dose of 120 to 140 mg per kg per day. Phosphorus at a dose of 60 to 90 mg per kg per day. Once total volume of feed is 100 ml per kg per day, and this has to be continued being down. As I know, the calcium and phosphorus is extremely important for bone growth and it has many other functions too. Vitamin D requirement is over 1,000 international units per day till 6 months. That is Government of India recommendation. Iron should be started at a dose of 2 mg per kg per day from 2 to 4 weeks till 6 months. Different guideline recommendations are given by mostly a sector, AAP, SOGAN, etc. And now coming to more data, very preterm babies, that is babies less than 32 weeks and less than 1,500. These babies may need more respiratory support, warmer care, incubator care, this is important. And these babies need to be started on orogastric feeds. And mostly we can start full feeds on day 1, 60 ml per kg per day if possible. Otherwise, these babies may require feed is not tolerated. Babies may require extra IV feeds also. And so in these cases, mother will be separated, encourage early mother involvement, early parent participation, encourage kangaroo mother care, and supplement these babies also require supplements, calcium, phosphorus, vitamin D, iron, etc. as we discussed in the previous slide. And the transition to oral feed has to be careful. We have to observe and the readiness to validate feeds. And NNS can be NNS using empty breast as well as aspirate can be tried to help the baby getting transition to full oral. Now coming to the last group, that is ELBW babies, extreme low birth weight babies. They need aggressive nutrition, early aggressive nutrition, and when growing phases there you need enteral nutrition and fortifiers and post-discharge care. Infants receiving early and adequate parental nutrition regain birth weight more quickly and experience improved weight in a tempo. So parental nutrition, amino acids, lipid, central line. Also, maximum aggressive nutrition is the recommendation. You can start with 3 grams per kg per day of amino acid and 1 gram per kg per day of lipids. This is to avoid protein catabolism and also to promote early enteral feeds should be started. Enteral nutrition can be started as early as possible to encourage express breastfeeding. Mothers can be motivated by during antenatal counseling, and she mostly given trastuzumab, she will be able to express breast milk as early as 6 hours. She needs emotional support. And mostly these babies are very small and beyond the respiratory support on tubes, and also mothers need more support. Encourage KMC. And what are the benefits of minimum enteral nutrition? When the minimum enteral nutrition helps in maturation of gut immunity, more enzyme maturation, and also increase mobility, and helps in the early achievement of food peace. And one word about oral colostrum care. And when you get colostrum, 0.1 to 0.2 ml of colostrum can be applied to each cheek using a tuberculin syringe, and this will help in stimulating the local immunity, and it also helps against the microbial infection also. And the studies have shown that oral colostrum care reduces sepsis, injury, and shortens the length of hospital stay. And non-nutritive sucking, again, this is extremely important. Improves swallow coordination, facilitates transition to oral feeds, helps in early attainment of oral feeds, and early hospital discharge. NNS can be tried using empty breast and pacifier. When you are offering this, NNS can be offered to a hemodynamically stable baby. And when you are offering this NNS test to the baby, always do this under monitoring. Mothers may not be very much knowing about the risk. So babies are very tiny, small, and the breast is not, mostly it will not, the baby will not be effectively sucking, only small such, so always do this under monitoring, careful monitoring. Babies can swallow and suck the similar as early as 14 to 15 weeks, but consistent swallow develops by around 22 to 24 weeks. But we know that suck, swallow, breath coordination happens only when the baby is mature beyond 34 weeks. Choice of milk, mothers on milk is the first preference. This is the best, and second choice is pasteurized or human milk. That is also not available. Next choice is preterm formula. And all units should have a standard feeding regimen. This is extremely important. So, what is the choice of milk? When to start and milk feeds? How much volume to start? How much to increase daily? And at what intervals? When to start, fortified, etc. So, when to start? It can be started as early as possible. So, the early prescription, early breast pump, motivation for using breast pump and getting EPM and starting this EPM early is extremely useful and is good. And how much to start each week, that is based on the gestation. The baby is less than 28 weeks, maybe we start at 10 ml per kg per day. Studies have shown that early starting and rapid increasing feeds can help to achievement of early full nutrition, full feeds, and also in early hospital discharge without increasing the risk of injury. Anyway, this has to be done under monitoring. And how much to increase daily, this also is based on gestation. For bigger babies, more than 30 days, you can increase daily around 30 ml per kg per day. For smaller babies, maybe 20 to 25 ml per kg per day. At what intervals? Babies beyond 30 to 32 weeks, feeds can be given at an interval of 3 hours. But smaller babies, can be at 2 hours. When to start fortifiers? Again, different recommendations are there. Normative India recommendation is to give start fortifiers and enteral nutrition, dental feed has reached 100 ml per kg per day. So the total orogastric feed volume is around 100 ml per kg per day. Then you can start human milk fortifiers. Fortifiers are used to improve the nutritional content of breast milk. Breast milk, we know, breast milk, the protein calorie may not be sufficient for the growth of this extreme small baby. So they require fortification of breast milk. So this will take care of calcium, phosphorus, protein, calorie, and many minerals and vitamins. So that's important. This is usually started to prevent the catch down of protein after the parental nutrition. When you are starting the enteral nutrition, there can be fault, like growth can come down. To avoid this and to prevent this, the enteral nutrition is fortified, and breast milk is fortified with human milk fortifiers. Mostly maybe 1 gram per 25 ml is added. That 1 gram sachet for each 25 ml is added, and this is given to the baby. And again, there should be a plan for when to start mineral supplements and iron that we have discussed in the previous slide. And when to stop is also important. Usually, calcium phosphorus supplements are stopped when the baby reaches term. Iron should be continued for 6 months to 1 year, and vitamin D should be continued till 1 year. And this is the most important part. Whatever we are feeding our baby should be truly appropriate. So baby's length, weight, and head circumference should be bloated, maybe at weekly intervals to know that baby is not losing much weight and not falling into centimeters. Transition to oral feeds. In these small babies, this is very important. Most preterm babies will show readiness for transition to oral feeds by 32 to 34 weeks. Techniques which promote transition to oral feeds are KMC, non-nutritive sucking, oral pacifiers, etc. And nipple shields have been tried to access overlatch. More important is the baby should be monitored during oral feeds, or it is MNS or direct feeds. These babies has to be monitored to avoid problems. So finally, this is our aim. Whatever be the gestation, whatever be the date to discharge the baby on full breast milk. Maybe small preterm babies require supplements also. So the learning points are low birth weight babies, even when they are term born, needs extra care, lactation assistance, and discharge should be a planned discharge, and long-term follow-up is required to ensure normal growth and development. Preterm babies need more intensive monitoring and care based on their gestation. More lactational support is required, and long-term follow-up is needed. Thank you. I hope you understood the presentation. Thank you.
Thank you, ma'am, for that very informative talk. Next is a discussion on neonatal screening and discharge checklist by Mrs. Anupama Madam. Ms. Anupama A, nurse manager in the Department of Neonatology in KIMS Hospital with more than 15 years of experience in neonatal care and management. She has won many accolades in national NNF quiz competitions as well as in examinations and well appreciated for her patient-friendly nature. I invite you, madam, to train us regarding how to screen a neonate postnatally and the discharge checklist to be followed for each newborn.
Good afternoon to all. Myself, Anupama. I am working as a nurse manager at the Department of Neonatology, KIMS Health, Trivandrum. Today, I am going to present discharge plan for a normal newborn. Who is a normal newborn? Normal newborn is a baby who is born between 37 weeks and 42 days, whose birth weight between 2.5 and 4 kg, whose clinical examination should be normal, and baby should be hemodynamically stable. Why planning is needed for such babies? To avoid unnecessary long stay in the hospital, to ensure safety of both baby and mother, and to prepare mother for neonatal care and follow-up aspects, we have to plan discharge properly. For this, we have to go through certain checklists. That is, first one, hemodynamic stability. Second, lactation should be established. Third, routine lab should be completed before discharge. Immunization should be completed before discharge. Hearing, screening, and pulse oximetry part should be completed. And family should attend pre-discharge counseling before discharge. We have to start vitamin D for such babies, and we have to plan follow-up care for such babies. We will go through the checklist one by one. First one is hemodynamic stability. For assessing hemodynamic stability of the newborn, we can use an electronic stores. That is, S stands for sensorium, T for temperature, O for oxygenation, P for pulse rate, and S for sugars. That means baby should be active. Auxiliary temperature between 36.5 to 37.4 degrees Celsius maintained with appropriate clothing. There should be no distress, no tachypnea, and baby should maintain an oxygen saturation of more than 95% in room air. Coming to the pulse rate, awake heart rate between 100 to 170 per minute can exert up to 70 per minute. Sleep provided heart rate quickly picks up when active. Persistent heart rate more than 170 and less than 90 needs attention. Coming to the sugar part, there is no need to check GRBS for all babies, but we have to check GRBS for those babies who are at risk for hypoglycemia. Pre-feed GRBS 60 to 125 mg/day, don't for 8 hours. GRBS more than 50 centimeters within 48 hours. Then coming to the second checklist, that is lactation should be established. We have to make sure that the mother is able to feed the baby before discharge. A large score of 8 to 10 is considered as good. Score of 4 to 7 is moderate, and score of 0 to 3 is poor lactation establishment. We can't discharge those babies. In the large score, L stands for latch, A for audible salary, G for type of build, C for comfortness of the mother, and H for hold. How comfortably the mother is holding the baby. She needs help or she can independently hold the baby. Baby should pass urine and meconium, no more than expected weight loss. Expected weight loss in the first 3 days is up to 10%. That is 3% per day. Then the most important thing, mother is confident with eating. Then coming to the third checklist, that is routine largely completed. Routinely we are doing blood group, bilirubin assessment and thyroid screening before discharge. For bilirubin assessment and for follow-up, we are using this Usari nomogram for our specific nomogram. We will plot the value, bilirubin value in this chart for assessing the need for phototherapy. Then coming to the newborn metabolic screening, it is not universal in India, but Chandigarh, Goa and Kerala have implemented in government sector and certain private hospitals are doing that. In Kerala, diseases screened are congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia and G6PD dehydrogenase. For newborn metabolic screening, we have to collect ELPIC sample in a filter paper. And before discharge, we should convey the family that it should take 21 working days to get the report and they have to follow the report. Then coming to the immunization part, we have to complete birth vaccines, that is BCG, OPV and hepatitis B before discharge. In certain hospitals, they are giving hepatitis B along with the vitamin K. Whatever it may be, we have to complete these 3 vaccines before discharge. Then coming to the 5th checklist, that is hearing screening and pulse oximetry. Universal hearing screening in Kerala, all government hospitals and majority of private hospitals doing OAE before discharge. We have to make sure that baby should pass OAE. If they fail in that test, we have to repeat the test before the next vaccination, that is 45 days vaccination. We have to complete the test. If the baby fails 2 times in OAE, we have to refer the baby for para test. Then coming to the pulse oximetry screening. Pulse oximetry screening is done after 24 hours of age to rule out congenital cyanotic heart disease. As a result, we will get either fail or pass or retest value. Pass means pulse oximetry of 95% or more in right hand and good and a difference of 3% or less between the two. Then do not repeat pulse oximetry of a normal newborn care. Retest means pulse oximetry of 90% to 94% in either the right hand or good, or a difference of 4% or more between the right hand and good. Then what we have to do? We have to repeat pulse oximetry measurements in 1 hour. Then when we are taking the second measurement, we are getting a value of 95% or more in right hand and good and a difference of 3% or less between the two. Then baby will pass in the test. Then we can continue the normal newborn care. If we are getting an estimate of 94% or less in either the right hand or good, or a difference of 4% or more between the right hand and good, that means the baby is failed in the test and do not repeat pulse oximetry screening. Refer for immediate assessment. That means the baby needs cardiology consultation or an echo. In the first time itself, we are getting an estimate of 89% or less in either the right hand or good. That means the baby failed in the test. Then do not repeat pulse oximetry screening. Refer for immediate assessment. But before concluding, that we have to make sure that the baby is not crying or moving. That value we can't relate. Then coming to the pre-discharge counseling, this is a main part of discharge planning. Before discharge, we have to make sure that the family should attend pre-discharge counseling. In that, what are all the things we have to do? We should convey the family regarding normal newborn care, troubleshooting in breastfeeding, then personal hygiene, especially in this COVID crisis. We have to explain the family regarding danger signs in newborn also. What are all the danger signs? Lethargy, poor feeding, hypothermia, hyperthermia, convulsions, abdominal distension, yellow colored only, yellow soles and palms. These are all the things we have to convey the family. Then coming to the seventh checklist, that is vitamin D. As babies are less exposed to sunlight, we have to provide vitamin D 400 international units per day till 1 year. We have to make sure that we started vitamin D for all normal newborns before discharge. Then coming to the eighth checklist, that is follow-up care. It is also important. It is always ideal to have a first follow-up within 1 week or early as per baby's clinical status. That is early will follow-up, early dated as per advice during discharge. Follow-up visits and vaccination to be planned. Let me conclude once more with this checklist. That is, first one, we have to measure hemodynamic stability of the newborn before discharge. Lactation should be established. Then we have to complete routine labs before discharge. Then immunization should be completed before discharge. Then pulse oximetry and hearing screening part should be completed. We have to make sure that families should attend baby-side counseling before discharge. We should start vitamin D for all normal newborns. Then follow-up care also should be planned before discharge. What are the advantages of planned discharge? Planned discharge ensures mother and baby's clinical safety, mother's confidence, and it alleviates maternal stress, and it avoids unnecessary long stay in the hospital. Thank you.
Thank you, ma'am, for that useful information delivered in a simple yet concise way. We are moving on to the last session of today's CME, that is on stabilization and transportation of sick newborns by Dr. Anju Madam. Dr. Anju J is the Senior Consultant Neonatologist in GG Hospital. She is a dedicated neonatologist with more than a decade of experience in this field. I invite you, ma'am, to discuss regarding how to stabilize and transport a sick neonate for expert care.
Good evening, all. I'm Dr. Anju. I'm working as a consultant neonatologist at GG Hospital. Today I'm dealing with the topic stabilization and transportation of sick. Neonatal transport was first used in 1960s in India. Outcome of critically ill babies is partly dependent on the effectiveness of the transport system. And facilities for neonatal transport in India are this one. So now it's not very great. Why is transport of sick patients necessary? Significant decrease in neonatal mortality and better outcome can occur if specialized care can be made available to sick neonates. What is the difference between self-transportation and organized transportation? Transport by a skilled, organized team reduces neonatal mortality and morbidity. For neonates needing special or intensive care should preferably be transported by a skilled transport team to an organized group. Types of neonatal transport can be from home to hospital, like a delivery happening at home, or a baby who is at home becomes sick, they have to be transported to hospital. So intra-hospital transport from the labor room or the operation theater to the neonatal ICU if the baby is sick, or the baby taken to some other part of the hospital, like for doing an echo or for taking an EEG, etc. That is intra-hospital transportation. Now, to facilitate specialist management of the neonate, the baby may have to be transported from the hospital to a center where the specialist care or specialist management is there, like for taking an echo of the baby, for an expert opinion by taking an echo, or for taking an expert opinion from a neurologist in another hospital, the baby may have to be transported. Retrieval from a peripheral hospital for ongoing intensive care, which means the baby may be delivered in some other hospital and may have to be taken to another hospital for better care or for specialist or for intensive. And once the baby is stable, this baby will be shifted back to the primary unit, that is a returning infested local neonate units following care elsewhere, which is known as reverse transport. Which babies need transport? In short, any baby which is extremely preterm or small or is sick will need a transport from either from home or from a center where the care is not available to a specialist center. So, very low birth weight baby, infants less than 1.25 kg, premature babies less than 32 weeks, babies with respiratory distress or apnea, babies having persistent sinuses, hypoxic ischemic encephalopathy with either assisted ventilation or seizures or multi-organ involvement, sepsis with signs of systemic infection, jaundice with potential for exchange transmission, active bleeding from any side, infant of diabetic mother or hypoglycemia unresponsive to recommended treatment, surgical condition, heart diseases, heart failure, metabolic conditions, severe electrolyte imbalance, or infants requiring special diagnostic or therapeutic service. So, in short, any baby who is sick or who has a problem should be transported. The key components of neonatal transport system is human resource, vehicles and equipments, communication and family support, documentation and consent form, feedback to representative. So about human resource, it includes a person or a doctor who is capable of taking care of the newborn during transport. And in addition, we need other supporting staff for helping the doctor. So that is about the human resource. Then vehicles and equipment, all those will be dealing with. Now, during principles of neonatal transport includes assessment of the baby, stabilization before transport, care during transport. Pre-transport stabilization, you can remember it with any of these mnemonic: stable, safer, or tops. Basically, it includes sugar, temperature, oxygenation, which includes airway breathing, perfusion or circulatory support or BP support. All those come in perfusion, and there is emotional support for the family. So in stable, it is included sugar, temperature, artificial breathing, blood pressure, laboratory work, emotional support. Safer, sugar, arterial circulatory support, family support, environment, respiratory support. And CHOPS, it is temperature, oxygenation, includes airway breathing, perfusion, and sugar. What is missing in CHOPS is emotional support for the family. And in stable, one additional thing is laboratory work. L is for laboratory. So basically, everything is same: sugar, temperature, oxygenation, perfusion, and emotional support for the family. Now, first step during transport is assess the baby, and depending on the facilities available, check for the temperature, airway, breathing, circulation, and sugar. Step 2 is temperature management. Correct hypothermia is present before transportation. And the hypothermia itself is supposed to increase the morbidity as well as the mortality of babies. It is very important to correct the hypothermia. Next is airway. Assess the airway for presence of any secretions. Suction secretions are present. Position the neck by placing a shoulder. Breathing. Assess for respiratory distress. Assess whether baby requires ventilation. Circulation. Check the heart rate, capillary leakage time, urine output, blood pressure. Assess the need of food boluses. Check what fluids baby is getting and whether baby is on antibiotics, and adjust the dose of the antibiotics as per the requirement. Next, check the sugar. If sugar is less than 40, you have to correct it before transportation. Next is transport person. Mother or attendant, ASHA worker, trained nurse, paramedic or physician at the referring hospital. Anybody can act as a transport person. And equipment is ambulance is available if available, or any other vehicle, preferably draught, because draught can again cause sleep. Temperature maintenance. Use the transport incubator if available. Kangaroo mother care by mother or attendant. It's a useful way to maintain the temperature. Other methods like adequately covering the baby and using improvised containers like thermocol box, basket, polythene covering may help maintain the temperature. It is very, very important. Temperature maintenance is very important before transport and during transport. Airway and breathing. Keep the neck of the baby in slight extended position. If airway is unstable, it is better to intubate and transport. Intubation is not considered or not necessary, or it is not possible. You can consider short positive pressure ventilation or feedback can be provided using a CNE system. And circulation. Assess the perfusion, capillary leakage time, everything, and stabilize perfusion before moving the baby to the ambulance. Syringe pumps are required to use inotrope. So, stabilizing the baby before transportation is very, very important. That itself is one of the determining factors for the better outcome of the baby. During transport, again, you have to maintain the temperature, airway, breathing, circulation, feeds, and communicate properly with parent and the referring hospital. So feeds, we have to say during the transport, if it's a long distance transport, if the baby is on feeds, you have to give feeds according to the time interval perspective, or if you have to continue with the foods. Don't forget the feeds during the transportation. Communication to the parents and the hospitals is also very important. About the modes of transportation, the main mode of transportation, especially in India, is ambulance. And the ambulance, the speed of the ambulance should be only 10 to 20 kilometers per hour more than the speed prescribed in that area. It should not be very high because chances of accidents are more if the speed is very high. And as far as possible, the voice, the alarm should be switched off because that itself may cause problems for the newborn. Then another is helicopter or rotary wing, which is again an expensive mode of transportation, but is faster than ambulance. And with the help of a helicopter, the babies can reach near the hospital when compared to an aeroplane. So, but the problem is, one is it is costlier, and another is the noise which is caused by the helicopter, which may have problems with the newborn. Another mode is aeroplane or fixed wing aircraft, where the problem is the high cost. Another problem is when the aeroplane is in a high altitude, the chances of baby having pneumothorax because the pressure outside is low. So the lungs may expand and it cause pneumonia. That problem always is there. So always be cautious when traveling by aircraft. And if the pneumothorax occurs, it should be retrieved. So you should be aware of that. Another thing is, as we move higher and higher in altitude, the oxygen level in the atmosphere will be less. So for the baby, the FiO2 may have to be increased. One thing you can do to prevent pneumothorax is by increasing the cabin pressure. You can request the pilot to increase the cabin pressure so that the surrounding pressure is not very low, and because you can to some extent prevent pneumothorax. What is the role of intubation before transport? Very sick, unstable babies will have to be intubated, like with babies with respiratory distress requiring FiO2 more than 70%, recurrent angina, recurrent seizures, congenital heart disease, that babies on prostaglandin even especially because of risk of apnea, congenital diaphragmatic hernia. And in case the limited space, the limited skill of the person accompanying the sick baby, it is better to intubate. What should be done in case the neonate deteriorates during transport? This is one scenario which most of us will face once in a while. In that case, stop the vehicle, resuscitate the baby. If skill and space is available, you can do the procedures inside the vehicle, like intubation, chest tube insertion for pneumothorax. Don't perform procedure in a moving vehicle. Get to the nearest hospital, stabilize the baby before proceeding further. Now, how should one communicate during transport? Communication with the parents is very, very important. You have to explain to them the nature and severity of illness and the need for transport of the baby. You should explain to them the facilities available in the referral hospital, including the infrastructure, details of the key personnel, the type and mode of transport, the time needed to reach the referral hospital, names and contact numbers of key personnel at the hospital, possible need for emergency procedures during transportation, availability of bed should be asked before starting transport, and referred hospital should be informed in advance, which is also very important. Before reaching the referral hospital should be able to make arrangements to visit the baby. So it is very important to inform them about the condition of the baby. What are the requirements, what is the condition, and how is the baby? You should explain to them either through a telephone or through a fax or through an email. Anyway, you have to inform them before sending the baby. What about the referring institute? What are the responsibilities? All the patient details should be recorded, the reason for transport, detailed history, perinatal history, labor and delivery history, naming institutions, all those histories should be recorded. Current patient status, therapy, and laboratory data should be entered. Potential need for deterioration and need for advanced therapy should be mentioned. The referral note, provisional diagnosis, and treatment so far should also be recorded. Also be told to the referral hospital. Another important thing is consent form from the parents. If unfortunately the baby dies during transport, which also can occur at times, what should be done? Ambulance should be stopped and do CPR according to the NRP guide. If the baby dies on the way, he or she should be taken to a higher health facility, the nearest way. Casualty admission should be done. Parents should be explained, and death certificate made by the medical personnel of higher healthcare facility. It is the responsibility of the transporting team to make death certificate of the baby. What are the equipments required for neonatal transport? All the equipments like thermal support equipment, respiratory support equipment. I'm not going into all these each one. Suction equipments, monitoring equipment, parenteral infusion equipments, medication. These are in general the broad headings. And the most important thing is, before transportation, you have to make a checklist of things and check whether all these things are there in the properly placed in the transport system. Or what will happen is you will miss something, and during the resuscitation of the baby, you will find it difficult. This is the sample referral note. You can see all the details of the baby is entered, birth details, all the clinical course, then the type of feed, reason for referral, examination findings, then investigations, treatment given, mode of transport, everything should be there in the referral note. And this is another sample of the consent form. We should include the name of the baby, the relation of the bystander to the baby, the name of the doctor, name of the referring hospital, and the reason for the referral. And it should be mentioned in that unexpected emergencies may occur during the transport, which may have to be dealt with. Sometimes there may be problems during transportation. Then a signature, duly signed form should be kept in the file. Signature of the parent and signature of the doctor also should be there. In short, neonates needing special or intensive care should preferably be transported by a skilled transport team to an organized teamwork. Teamwork is very, very important during transport. Appropriate equipments and vehicles customized for movement should be available for safe transport. Pre-transport stabilization is the most vital step in the whole process of transport. Adequate and timely communication with the family, referring hospital, and the support group is essential. And one more important point I stress is that in utero transport, if possible, if you're expecting a problem with the newborn, if possible, you have to ship the mother with the baby, because that is the best method of transport. Sometimes you may have, most of the time, you may have to transport the baby once the baby is born. Okay. So in that case, all this the appropriate equipment, the transport stabilization, timely communication, all these are. I hope I have made it clear for you. Thank you for the patient listening.
Stop sharing. Thank you so much, madam, for enlightening us on an important topic. With this, we come to the end of today's online CME session. Hope you found each discussion topic helpful and hope you all will apply the knowledge gained today in your future practices in essential newborn care and management.
PMC sir, Manoj sir, anything more to add?
I think we had a very good session. I hope it really people will read again. Once again, we will share the slides, Kamala. I think
Yes, ma'am. If you can send me the PowerPoints, I can share it with the delegates.
I have sent it. Yeah,
they will appreciate it, right?
I have already sent it. Yeah.
Okay. And they can continue posting their questions. The WhatsApp groups will be active for another couple of days at least till we send out the PowerPoints to them. They can still share questions after they think. If they have more queries, they can of course post it in the WhatsApp group, and all the faculty will be very happy to answer their questions also. And regarding the e-certificate for all the participants, we will make the e-certificates and send you within the next 1 week by email.
Sir, unmute, sir.
Unmute, sir. PMC sir,
yeah, I think the whole different discussions are really useful for them, for the nursing staff. So I should thank all the panelists as well as the delegates, a large number of the delegates who took so much time and heard patiently. Thank you very much. Thank you, Kamala and the team who did so much hard work.
Thank you, Kamala.
Thank you, sir. Thank you, ma'am. Manoj sir, anything more to add? Radhika?
So congratulations. I think this is a wonderful start to our Neocon. There are a lot of apprehensions because of the online mode, but Dr. Kamala and team headed by PMC sir has done a wonderful job. And we have 3 more days to go. And I hope everything goes smoothly. So thank you again, team, and the compeer also special mention. She did a good job. So thank you all and all the attendees. Thank you all. And I think it was wonderful.
Thank you, Radhika. Thank you, sir.
Thank you. Thank you, Radhika.
And the delegates also stayed till the end after a long session. I think 80% of them stayed till the end anyways.
Yeah.
Okay, so we will conclude the session now.
Okay, thank you, Shilpa.
Thank you all for your enthusiastic participation and cooperation. So as mentioned, we'll be sending the e-certificates of participation for all those who have attended within 1 week. And I'll conclude with one final thought to ponder. The capacity to learn is a gift. The ability to learn is a skill, but the willingness to learn is always a choice. Thank you and have a nice day.
Wonderful.
Thank you, sir.
Thank you. Thank you.
Thank you.